Before I start telling you about what this webinar is about, welcome to everyone who's joined so far, and we're still growing in numbers. This is a webinar on tendon injuries and management. It's the second webinar in a series that's being run between the BSSH, British Society for Surgery of the Hand, and BFIRST, 150 people almost, and BFIRST is the British Foundation for International Reconstructive Surgery and Training, which is the charity arm of BFIRST, which is the Plastic Surgery Association that is in the UK. So welcome everybody to this afternoon. We basically have a pretty kind of intense afternoon's webinar for you. I will just start off by sharing this PowerPoint screen, and I hope can somebody stick their thumbs up amongst the panelists if you can see it. Great, thank you. So these are the learning objectives, and you'll get an MCQ at the end that is based on this. Don't worry, we're not going to shame anyone. We're not going to expect you to come on live to answer any questions or anything like that, but feel free to ask questions and so forth through the Q&A function that we've got on the go here. Essentially, you know, the bits in red are your learning objectives for this afternoon. It is fairly rapid fire. We've got a combination of videos that we're going to play. We have some live presentations. Essentially, we're going to be talking about flexor and extensor tendon anatomy, how to repair them, and then a really important part, the role of the therapist in all of this, which does tend to be not focused on outside countries like the UK, I guess. So I really hope you pay attention to that. And then finally, some stuff on how to salvage tendon repairs when things don't work. So I'll just finish off this little intro by saying, once again, welcome, and I will hand over to the first of our faculty. You'll get to know them quite well as the afternoon goes by because they're giving more than one talk each. So if I can hand over to Tony Barabas, plastic and hand surgeon, take it away. Thank you.
Right, thank you.
I'll stop.
So Tony, or Anthony Barabas, I'm a plastic and hand surgeon in Cambridgeshire, UK. Can I just check with the panelists? Everyone, can you hear me okay? Can you hear me?
Yes, we can. Thanks, Tony.
Yeah. And
yes, we can hear you.
And you can see the whole of my slide, filling the whole of your screen. Is that right?
Yes. Yeah, go for it.
Okay, so flexor tendon anatomy. Well, this first picture really describes everything that I'm going to talk through just in one very good image. The flexor tendons of the arm are the FDP from the ulna going to the distal phalanges, the FDS from the superficialis arch going to the middle phalanges, and FPL from the radius going to the distal phalanx of the thumb. To test FDP individually, it's best placing a thumb or immobilizing the middle phalanx and asking the patient to test flex the distal phalanx. The tendon itself is formed of two large bundles of collagen fibers with a little groove down the center, as actually is the FDS beneath, though at this point it's a little bit flattened. And as David Elliott, one of the hand surgeons in the UK, has shown, you can actually, for most activities, maybe excluding that of rock climbing and lifting the whole weight of the body, you can actually perform very heavy tasks with just a single bundle from the FDP tendon. They are conjoined together, so they will tend to act as one. So that's why you need to immobilize just proximal. The FDS tendon, it's lying above the FDP tendon up to the level of the metacarpal heads. It then splits into a radial and ulnar slip, which wraps around the FDP tendon as it progresses over the proximal phalanx. It reconstitutes behind the FDP tendon as campus chiasm to then insert onto the middle phalanx. To test the FDS, again, it's best to immobilize just proximal to the joint that it moves, being the PIP joint. So you immobilize over the proximal phalanx, but you do also need to immobilize the other fingers in extension. And that is because the FDP tendon runs past the FDS in any finger that it's applying. And so the FDP tendon will always have an action on the PIP, the proximal joint. So to prevent the FDP tendon from bending in also at the PIP joint, you need to hold the other fingers out straight. And that's because the FDP tendons are joined together in the wrist. So when you hold the others out straight, you're holding the muscle belly from being able to contract. So it can't contract on the finger you're testing. And so you're only testing the FDS tendon to that finger. And you need to do that for every finger that you're examining. But remember that in the little finger, up to 1 in 4 people will not have an FDS tendon. In fact, 1 in 4 people who might not have a tendon, they could on the other hand. So there's even asymmetry between left and right hands. So this is the picture below shows an example of someone who does not have an FDS tendon and they can't bend at the PIP joint. The pulley system is what holds the tendons in against the bones and adds efficiency to the movement of the tendons. They're numbered annular pulleys beginning with an A and cruciate pulleys beginning with a C. The annular pulleys that start with, which are odd numbered, so 1, 3, and 5, are located over the joints. So the MCP, the PIP, and the DIP joints, whereas the even numbered pulleys, the A2 and the A4, are over the proximal and the distal, proximal and the middle phalanx as shown. And these are the more important pulleys. And actually the cruciate pulleys functionally make very little difference. They're there really just to allow movement because they collapse in as the fingers bend. Oh, how did I end that? Oh yeah, so this is the picture of the, hang on, this is I think the last slide. I've managed to somehow jump slides. Can I just stop the talk and restart it? I think let me just get to the next picture in the slide. It jumped right to the very last slide in the talk. Right, so here we go. So this shows why the pulley system are important, because the A2 and the A4 pulley in particular hold the flexor tendons into the bones as the finger flexes, so that you don't get bowstringing of the tendons because they're held in as the finger flexes up. The pulley system should be preserved where possible during surgery, and in particular the A4 and the A2 pulleys. And so you try to make openings and windows around them wherever possible. I use this technique of going down the edge of the pulley system and then across to lift these small little flaps. The importance is to remember how the FDS goes between the two portions of the FDP tendon passes between the radial and ulnar slip of the FDS tendon as shown here, leading to the campus chiasm posteriorly. And this is the position of where the A2 pulley is. So the A2 pulley really lies over the top of this important part of anatomy where the FDS is splitting and the FDP tendon passes through the center, with the A4 pulley more distally. The vinculae are small little blood vessels that pass up in loose areolar tissue and supply blood supply to the tendons. The blood supply also comes in from the musculotendinous junction and distally where they insert onto the bones. And when the tendons are inside the flexor sheath, they also get nourished by the flexor sheath fluid that's going around them. But otherwise, these vinculae are the blood supply, with the blood vessels coming in dorsally. And in fact, the volar quarter of the tendons are often quite avascular. These vinculae can actually prevent a lacerated tendon from retracting completely. They do have some power. And part of the reason when you've seen someone with a lacerated tendon, you'll put a dorsal hood on the finger is to prevent the tendons pulling back any further and rupturing these blood supplies. And as I mentioned, within the sheaths themselves, then the tendons also get nourishment from the fluid around them. Verdun gave the name the zones of the hand, with zone 1 being from where the FDS tendon inserts onto the middle phalanx distally. So in this section, you only have the FDP tendon. Zone 2 was described as no man's land, because this is where the FDS and the FDP are both found, and it's where that chiasm is the separation of the FDS into the two slips, and the chiasm is formed. And it was called no man's land, as it often had the worst surgical outcomes. Zone 3 is in the mid-palmar region, otherwise known as the lumbrical origin region, and this is where the lumbricals come off the radial side of the tendons. And zone 4 is under the carpal tunnel, and zone 5 proximal to the carpal tunnel. So talking about the lumbricals come off the radial side of each of their respective tendons. If you have a defect in the FDP tendon, because they only come off the FDP tendon, then you'll get shortening of the FDP tendon. This will pull on the lumbricals. Now the lumbricals insert onto the extensor hood. So by inserting onto the extensor hood, when the FDP retracts, you'll actually start to extend the fingers. In normal function, the lumbricals allow for a large span of grip so that you don't just curl up in a simian type fashion, but the hand comes out and forms a grasp around larger objects, because it doesn't immediately curl up at the PIP and the DIP joint. So that's their function. So obviously when you have a divided FDP tendon, the lumbricals are being pulled more than they would otherwise. And what can happen is the finger which has the defect of the FDP tendon, they can't flex it in as much, because when they're pulling, it'll start to extend. And in the thumb, the most important of the pulleys is actually the oblique pulley, which goes across the proximal phalanx. In the carpal tunnel, the superficialis tendons lie above the other two, with the superficialis to the middle and the ring finger being the most superficial. And so there's the final picture, just with the metacarpal, middle phalanx, sorry, proximal, middle, and distal phalanx, showing all the various structures that I've discussed. Thank you very much.
Marvellous. Okay, so the essentials of extensor tendon anatomy then. Generally, the extensors is divided into extrinsic and intrinsic extensors, and we'll just quickly rattle through these. So the extrinsics come from the forearm, and you can subdivide them by where they come across at the wrist, underneath the extensor retinaculum, because at this point they come through at on six different compartments. So starting from the radial side, you've got abductor pollicis longus, extensor pollicis brevis. Next one round is extensor carpi radialis longus and brevis, extending into the base of the second and third metacarpals respectively, and they run underneath the first extensor muscles in the distal forearm, and stay in that position. EPL is the third one, which is the other side of Lister's tubercle, and that runs over the second compartment, as you can see there. And then the main bulk of extensors, extensor digitorum and extensor digiti minimi, come through the fourth compartment on the back of the radius there. Extensor indicis tends to be a little bit deep, and then the fifth one is over the distal radio-ulnar joint, extensor digiti minimi, and then extensor carpi ulnaris over the ulnar, and so the position of that changes in supination and pronation slightly. Coming into the hand, you can see there that the tendons are flat and ribbon-like, and they're joined together by these juncturae tendinum. There's a variable number of tendons passing between, passing up the hand and into the fingers, and so typically you have a single extensor indicis and a single EDC to the index and middle, but particularly on the ulnar side of the hand you can get bifid arrangements. Number 3 there is actually the EDC contribution to the little finger, which is just a glorified juncturae. And this happens in slightly more than 50% of the population. So often you actually have a double EDM to the little finger, but there's frequent variations within this. As you extend into the fingers, the appearance can be quite complex, but if we stay with the extrinsic tendons to start with, it splits into 3, and you have a central slip and two lateral slips. The lateral slips separate, allowing the central slip through to the base of the middle phalanx, and then the lateral slips come together in the terminal tendon, inserting into the base of the distal phalanx. They're supported from slipping and sliding over the tendon by a number of other structures. And so you have the sagittal band over the MCP joint that acts as a hood, and it keeps the extensor tendon centralized. Both proximal and distal to this, you then have the intrinsic insertion. So proximally underneath the hood is where the intrinsic tendons insert into the base of the proximal phalanx. But beyond that, they insert into the sides of the extensor tendon, the lumbrical on the radial side, as Tony said, and then the intrinsics on both sides. Beyond that, over the PIP joint and DIP joint, you've got a very similar arrangement with a transverse retinacular ligament in lieu of a sagittal band. And then instead of the intrinsics coming in obliquely, you have the oblique retinacular ligament of Landsmeer. But that doesn't have a muscle as part of it. It just attaches from flexor sheath into the side of the tendons. And then as far as the thumb's concerned, we've got the 3 tendons from compartment 1 and compartment 3, and each tendon inserts into a base of a subsequent bone. So APL into the base of the metacarpal, the EPB into the base of the proximal phalanx, and EPL into the base of the distal phalanx. And that's your lot. So that's extensor tendons in a nutshell.
Thank you very much, David, and thanks, Tony, as well. I can open the floor up to questions. Please do send your questions through the Q&A box at the bottom of your screen. If you do want to actually ask your question in person, stick your hand up, and if we have time, we'll let you do that. But we are a bit tight. Any questions from anyone? I can't see anything at the moment.
Yeah, there's a message from the chat. What's the function of the juncturi intertendini? What a very good question. Next. No, they seem to adjust the balance of the extensor pull, and they're quite useful from that point of view in disseminating the load. And so you get a spread of lines of pull, but beyond that, they're just there to stop the tendons retracting too much when they're divided. I don't know if you've got any thoughts, Sarah or Tony, or anyone else.
No, nothing extra to add really as a comment.
I can't even spell it. We've got another question, a couple of questions here actually. We've let me just make this a bit bigger so I can read the whole box. So we have a question. What can you please explain the extensor tendon excursion over the proximal phalanx as it relates to rhomboideus of Wislow? Does that mean anything to you?
No, it doesn't.
No? Okay, we will Google that and get back to you.
If the questioner can put that in a different context, I'm not sure of. Eponymous names I've always struggled with.
Let's go to a more general question, and then we'll move on after this if it's all right. What advice do you have to medical students to break down the anatomy, I guess, into manageable chunks? This was sort of going to be my question to both of you. What's the sort of, I'll tell you what, one key point that I think a medical student should take away from each of your talks about flexors, about extensors? Tony, go first.
I think it's important to know some of the surface anatomy of where the flexors are and where the sheaths are. I didn't talk about that entirely. So, for instance, the A2 pulley doesn't actually. The proximal phalanx isn't just the bit where you see at the end of the palm going up to the PIP joint. The proximal phalanx starts back here. So it's all very well knowing all the anatomy underneath, but you have got to be able to associate it with the surface anatomy. So the A1 pulley is actually starting right back at the metacarpal head here in the palm. It's not. I have seen a number of medical students think that it must be starting here because that's the beginning of the finger, isn't it? Well, actually, the finger starts back here. It's just that this bit of it is hidden by the web space. So it's being able to relate everything to your surface anatomy, because when you're coming into surgery in that first incision you've got to make, your confidence is all to do with what you're going to find underneath that area. You've got to know where to make your incision. So I guess that's the important first thing to learn.
Same question to David.
Yeah, the essentials of the extensors. I'd like to think that I kind of just covered that in the talk, but I'd break it down by extrinsic and intrinsic. I wouldn't get too hung up on the little branches over the dorsum of the hand, and it's working out the muscle and where it inserts into. So I'll talk a little bit more with the tendon repairs and reconstruction about balance and length, and that should explain things a little bit more. But we had to put the anatomy in first so that you could understand the principles behind the surgery a little bit later on.
Thanks, Dave. I'm going to move us on because we're already a little bit behind. I guess I always learned my anatomy once I knew how it could be applied. So why don't you put your anatomy essentials into context in terms of what you hear over the course of this afternoon, and then if you still have questions about basic anatomy, come back to us. Let's move on to the next section, if that's all right. Again, it's over to Anthony Barabbas about WALANT, wide awake local anaesthesia for hand surgery, tendon surgery. So if I could just ask you to share your screen and please go ahead. Thanks.
Okay, so thank you very much. Yeah, so I'm based in the UK. So wide awake local anaesthesia with no tourniquet was brought to the front by this gentleman, Professor Donald Lalonde. He basically advocates it because if you use a tourniquet, you only get 15 minutes whilst the patient's awake. And actually, when they're asleep, you still only get 2 hours before you have to release the tourniquet. So the problem with the tourniquet is it results in increased bleeding. So there's a higher hematoma rate if you use tourniquets than not using tourniquets. And that is because you get a reflex hyperemia once the tourniquet is let down, but you also compromise the clotting factors because of a local acidosis. So the advantages of WALANT is it saves time because you don't need your anaesthetist. There's less post-operative pain because actually you can't do the surgery unless the patient is already pain-free from the WALANT, the block that you've put in. There's less post-operative bleeding from what I've just mentioned, and you don't need to stop anticoagulants on the whole. I certainly don't stop warfarin or aspirin. There's an improved patient outcome because with tendon surgery in particular, you can interact with the patient so that you can actually test whilst they're awake that your repair is working. And there's definitely a cost saving, partly because of no anaesthetist, but for other reasons I'll get into in a minute as well. Before I start, this is the bottle of local anaesthetic that I always warm up first of all. So I put it into a sink before I've removed the cap, warm it up to get it as close to 37 degrees body temperature as possible, because the closer it is to body temperature, the less pain it's going to cause on injection. I then also neutralize it by every single local anesthetic is an acid, and particularly those with adrenaline in, which are roughly the 1% xylocaine that I use is adrenaline of around 4. And so in a 20 ml bottle, I add 2 ml of bicarbonate. It's the 8.4% bicarbonate, and that brings it roughly to a tissue pH of 7.4, and so it's much less painful. I also, as Don Lalonde taught me, don't go in obliquely with a needle, go in vertically and just put a small, and this accounts to anywhere in the body, but particularly the hand, a small bleb of fluid first of all, before you then expand up further. If you go in at an angle, you're going to hit many more of the small branches and cause pain on the injection site. Also, by doing a small volume, first of all, it will start to take effect because volume itself can cause pain. Don't inject into the dermis. This is much more painful, again, because it's under pressure. And so volume and pressure mean pain. So put a small bleb in first of all, and then after about 45 seconds, just increase that up to around about 2 mils. And then I change the angle of my needle and I start advancing the needle, but only after I've blown a local anesthetic in advance of the needle. So he calls it the blow as you go technique. Certainly when I was in medical school, we were always told to put the needle up to its hilt and then retract on the plunger whilst withdrawing the needle to try and make sure we haven't gone into a blood vessel. The problem with this is that you go through all of the little branches, causing a lot of pain. So you've already hypersensitized the patient before you put the local anesthetic in, which is totally unnecessary, because if a little bit of anesthetic goes into a blood vessel, it's only going to add to the block you provide, because the doses that you should be using should all be toxic doses of local anesthetic, so that even if you put the whole volume into a blood vessel, which would be very unlikely with a needle passing through, then you still are not going to cause toxicity to the patient. So blow as you go. Don't do this. Don't put the needle in front of the local anesthetic. Blow the anesthetic in front of the needle. So when doing a case on the hand, I will inject about 4 to 6 mils in the palm. Start proximally, so it's starting to go numb before you move on to the next level. And then I'm blowing it in advance. So really they only feel the first injection. And I gradually work my way down the finger with 1 to 2 mil doses until the whole hand has gone pale. You should wait about 20 minutes for the local anesthetic to take full effect. But in fact, you can start operating earlier. You do need to have an assistant that knows what they're doing, because what will happen is that it will be a bit oozier. There will be a bit more blood in the operative field, and they do need to dab it away. But after a few minutes, it settles down, and it's pretty much like having a tourniquet on anyway, except that you can see that the digital artery is pumping away. This is Donald Lalonde's own hands. He did an experiment showing that you should always have phentolamine available to inject into a finger if you're worried that the adrenaline has taken too much of an effect. So I actually don't use it in patients who have brittle diabetes or Raynaud's disease or the likes. But if I did, I still have phentolamine available to inject. And so he's injected his left hand, which you can see around the injection sites, it's starting to pink up, where the white hand remains pale. But if you notice, even in the paler finger, there is still blood supply getting through to the tip of his finger, which remains pink. So patients can be awake whilst they're doing it, so you can interact with them. This is a patient that I've done a Dupuytren's release on, and this took longer than 2 hours, so we didn't have to have a break. It's particularly good for tendon transfers, so this is EI to EPL, and because you can get the tensioning done correctly at the time of surgery. This is a video of a patient that I've done, if it works, that is, that was awake whilst I was operating. And unfortunately, that video is not going to play, so I'll just skip on. But she's completely awake here. I've done, I've centralized her extensors over her MCP joints dorsally, and I've done it with her help, and so I could get the tension exactly correct. So I really use it for all aspects of my hand surgery, from nerve releases, ganglions, removing trapeziectomies, all trauma. My trauma list now is entirely local. I rarely use an anaesthetist. Even joint replacements I'll do under WALANT. So in summary, it increases productivity. You can do more patients on a list. There's less of time for anesthetic, less anesthetic time. There's no anaesthetist. It's safer for the patients. You get better outcomes, particularly in tender surgery. You can do it in the treatment room setting. You don't need to be in a main theatre, and there's a huge cost saving for it. So thank you very much for listening.
Thanks, Tony. We're going to have a Q&A session after the next talk, so do keep sending your questions in via the Q&A box or button at the bottom. But I'll just, Tony, I'll let you carry on with your next talk, seeing as you're in the zone, as it were.
Yeah, so next talk is surgical approaches, which
in the meantime, sorry, I've got someone phoning me. I'm just going to reject that. In the meantime, whilst Tony's getting his talk up and running, David.
Okay, this one is going to have to be a video now, because I'm not quite sure where I've put the other one of it. So I'm going to try and play it, and we'll hope you tell me if this works or not. Am I sharing my screen yet?
Not yet, actually. Sorry, my answer phone just apologies. I can't see your screen yet, Tony.
You can't. Okay, hang on a minute. Hang on.
In the meantime, a quick question about a textbook for hand anatomy.
Well, Green's is brilliant. Yeah, I use lots of different sources, but I will very often always go back to Green's as a my base textbook.
Well, I was just going to say exactly that. It depends on whether you're learning for pure anatomy or for surgical anatomy. Surgical anatomy, Green's. Pure anatomy, I think Keith Moore is a good book.
Yes, we're good.
Perfect.
Right, so incisions and approaches to the hand. Well, there are a multitude of incisions that can be made on the volar and the dorsal aspect. Considerations, you've got to take in consideration blood supply, the nerve supply, tendons, joints, how you're going to be mobilizing afterwards. Remember that a broken bone is a soft tissue injury complicated by a broken bone, a fracture that is. Blood supply on the volar aspect in the longitudinal pattern, you've got the palmar aponeurosis overlying major blood vessels in the palm itself. Looking at more detail, you've got the ulnar artery coming in, which leads into the superficial palmar arch, off which come the proper digital arteries before they divide into the palmar digital arteries, the common digital arteries before they divide into the proper palmar digital arteries. And so the ulnar artery really supplies the ulnar 3.5 digits of the hand, or certainly 3 digits of the hand. The radial artery does have a component which adds into the superficial palmar arch via this superficial palmar branch, but the majority goes dorsally round and via the first web space to provide blood supply to the thumb, the princess polyps artery, and then the thumb and index finger via the digital arteries. Looking at the surface anatomy, so radial artery, the deep palmar arch is coming dorsally through the web space. Ulnar artery goes through Guillon's canal, the pisiform and the hook of hamate, coming to the superficial palmar arch, which lies roughly at the level of the thumb web space. So again, the ulnar artery is mainly supplying the ulnar side of the hand, the radial artery supplying the radial aspect of the hand. Looking at how to make incisions on the hand, try and leave 90-degree angles at the tip of any flap. This will improve the vascularity. You're less likely to get flap tip necrosis. With a full Brunner's incision, you're aiming to go from crease to crease from the mid portion of the finger, so the mid-lateral point of the finger, coming right the way across the phalanx and raising up broad flaps, gives you a broad exposure. Hemi-Brunners, you're going to divide into half each of the length between the two. You'll also see that I put little extensions here because I put what's called a Y to V plasty, which I'll talk about in a minute. Skoog described a longitudinal incision down the center of the finger, and then when you close it with little Z plasties. In this picture, they've been placed across the joints themselves, which is a nice idea, but actually you tend to get more laxity in the mid portion between the joints, and it's easier to close. And sometimes your exposure is based on the injury, the laceration that you're presented with. If it's an oblique laceration, then you're more likely to do a Brunner's type incision. If it's a transverse one, you might convert that into mid-lateral incisions. So V to Y plasty, which I commonly do, you add little extensions to your running Z incision. And so what this does is you can advance those flaps when you close it into the little extensions, so that you actually end up with larger flaps, and this adds length to the scar. So particularly if you've got a condition such as Dupuytren's or a flexion contracture, you'll end up with the finger being able to come out straighter without the need for skin grafts. And a volar incision like this gives you a wide access to the structures underneath. You can pin it back or get them held back. I often just stitch back the tips of the flaps. Looking at the blood supply when you're raising the finger, well, it's a bit easier, I find, to look at it this way around, so that you've got the flexor tendon at the top. This is how you'd be presented with it, the finger, if you're operating. This incision is incorrect. You should not do an incision like has been shown in this book. The incision should come over the top of the digital artery and nerve, so the neurovascular bundle, on the side where you're raising the tip of the flap, and underneath the neurovascular bundle on the other side of the flap. And that is to maintain blood supply, because this neurovascular bundle needs to maintain blood supply to the dorsal bit of the finger, whereas this neurovascular bundle has to come into the base of the flap in order to supply blood supply into the flap itself. A midlateral incision, well, if you look at the line art picture at the bottom, they've put little dots. When you bend a finger inwards, if you look at the side of your finger with your finger bent, you can follow the creases exactly back to the midline of your finger, because they stop bang on the midline. So put a little dot at each of those points where the crease of your bent finger ends, and then join them together. And then when you straighten the finger back out, that is going to be your midlateral incision. And you don't really want to extend it beyond the web space, a line in line with the web space. Otherwise, you might start to take out the dorsal branch of digital nerve. You can then raise, this gives you good access to the extensor side on, so there's the extensor hood, and to the collaterals underneath. And for fractures and ligament injuries to collaterals, this is a good approach. Dorsally, the blood supply runs again longitudinally from a dorsal carpal arch. Dorsal carpal arch comes off the dorsal branch of the radial artery. And then the branches run longitudinally on top of the interosseous muscles, providing, then extending into a dorsal digital artery, which ends at the point of the PIP joint. Beyond the PIP joint, you can see that the blood supply actually comes from the palmar proper digital arteries. So actually this picture is not how I would raise, for instance, a cross finger flap. It does show from the side that blood vessels are coming in to it, but actually blood vessels along the dorsal part of the finger up to the PIP joint are more longitudinal, and they start coming in from the sides after the PIP joint. When raising on the back of the finger, a flap, you start again at the midlateral position, and you don't need to worry about the neurovascular bundles. They're volar at this point. So go down to the tendon and stick to the tendon, raising it up across to the other side. And in fact, it's the only consideration you do have to have is that the neurovascular bundle, or the artery at least, on the side that the flap is going to be based on hasn't been injured as part of the injury, because then you might want to raise the flap the other way towards the neurovascular bundle without the injury. So a laterally raised flap works very well off the middle phalanx. It will work off the proximal phalanx, but the blood vessels starting to come in from the side from the PIP joint onwards. As again, just reiterated here, you can see how beyond the PIP joint they're coming dorsally, and also so do the nerves with it. So a dorsal incision can be either longitudinal or curvy lateral. This will give you a good access to the structures beneath. I then do a longitudinal split of the extensor, and that gives access down to the bones. So it gives you access to all the structures you might require for whatever, bony fixation, whatever it is you're trying to do. Likewise, over the dorsum of the hand, longitudinal incisions gives very good access to all the structures. And because nerves and blood vessels are running longitudinally, you're going to cause very little damage there. Sometimes you might want to vary it, because a longitudinal incision near the base of the fifth metacarpal, you might take out the the dorsal branch of the ulnar nerve. So here it's been got a little white loop around it. But alternatively, you might want to do a zigzag incision to try and avoid it. It also gives you slightly wider access. Fasciotomy is important to mention that on the volar aspect, you make them on the radial and ulnar border of the thenar and hypothenar eminences to decompress them. And dorsally, you're going to make the incisions over the second and the fourth metacarpals, because that gives you access to all of the interosseous spaces So the first and second through the incision over the second metacarpal, and the third and fourth through the third incision. Your soft tissue loss might determine what you're going to use as far as flap. So you need to plan ahead. What flap might you use, and that might determine your access. And often the actual injury itself will determine what you're going to do, because here there's already a laceration formed on the back of the hand. Well, rather than do a longitudinal incision, it's much more obvious in this case just to extend the laceration that is shown. So in summary, plan your incisions based on the nerve and blood supplies of the anatomy underneath. Try and preserve scars going across joints, particularly on the volar aspect. They should avoid the joint by going to the mid-lateral portion, but on the back it doesn't matter so much. So zigzags on the volar aspect, straight on the back is fine. Plan in advance for what the ultimate exposure might be. So an extensile exposure, if something happens that means you've got to extend it, plan it in advance. It might determine what pattern you're going to do on the hand, and think about the mobilization afterwards. Thank you very much.
Thanks, Tony. I'm just going to, again, in the interest of time, just move straight on to where we left off with Dave Bell's video. So if you could just start sharing and just play where we left off.
There are a number of techniques to choose from. Is that working? I'll
yes,
start the repair with the back wall of the epitendinous suture, which I do as a simple running with 5/0 Prolene. I start on the side away from me at the mid-axis, tie a simple buried 2-throw knot, and run along the back. There's no core suture to be anxious about catching, so the bites can be reasonably chunky. On the near side, I lock it off with a simple over and over. I then leave it like that and go on and do the core. If I can't easily oppose the ends of the tendons without support, I'll do the core suture first. For the core, I favour the cruciate, which I find strong enough, it's simple and it's quick. It has 4 core suture strands and a simple locking loop in the 4 corners, but it will permit tension adjustment before you finally tie the knot. The design of the knot is 4 alpha loops in each corner that enclose the tendon fibres, and the shape of the knot from above is an equal sign overlaid by a multiplication sign, joined in each corner. From the side, it's an infinity loop with an extra twist. Visualise a triangle on the cut tendon end with the apex uppermost or volar. This marks where the suture comes through the tendon end. And I'll make the apex a double dot, the reason for which will become clear in a minute. You can start anywhere, but for clarity, I'll start here in the middle, with one of the longitudinal passes, part of the equal sign. Pass longitudinally along, and then up about 1 centimetre away from the cut end. This is just off the midline. Come round and re-enter the tendon 25% around the circumference of the tendon at the same level as where you exited. This is in the deeper or dorsal half of the tendon to get that 25% of the circumference. The needle then comes out at the apex of the triangle and you have your first alpha loop. You can see how in every orientation the loop encloses tendon fibres, so as it tightens, the fibres are strangled as a closed locking loop. The rest of the knot is repeating this configuration 3 more times, so we now reverse the order because we are superficial and central, so passing deep and out at the side in the deeper half of the tendon. This completes the oblique pass. Now out and over the top, 25% around, coming not quite to the midline. Enter here and start the longitudinal pass, which exits at the deep dot. So that's the second alpha. Repeat the sequence with 2 more alphas and you're done. The apex has 2 oblique passes coming through, hence the double dot. Six throws on the knot, and you can adjust the tension to bring the tendon edges to gently abut. I started in the middle for clarity, but there's a bit of debate about whether you should put the knot here, where tendon healing needs to occur, and so I start at one end of the longitudinal pass and bury the knot. You can now do the epitendinous suture, or if you managed the back wall before, you can complete it. I often do a silver skjold over the front. With this, you take transverse bites perpendicular to the tendon in the opposite direction to the direction of travel. The direction of travel is away from me, so the bites are towards me. End by entering the tendon and tie off the buried knot. Then it's really important to test the glide. This is easy under WALANT, otherwise a tenodesis test, or if you've had to do a retrieval, a tendon tug via the palmar incision. Vent the pulleys to allow glide if you need to. If it doesn't glide on table, then no amount of physio will ever be enough to make it work afterwards. That's it. Time to close. Put on a back slab pending therapy review after a couple of days of elevation. There you go.
Thanks, Dave. Let's again, we are falling behind, so I'm just a bit conscious that we need to finish in time. Should we just move on to the next talk straight away, and then we will have our first therapy talk after that, and then we'll do a Q&A session. So if I could again hand back to Anthony Barabas to talk about retrieval techniques. Sorry, Tony, I think you might be muted. I can't hear you.
How about now? Can you hear me now?
Yeah, can hear you now.
And can you see my screen? Flexor tendon retrieval.
See the screen, but we can see it before you've gone into presentation mode, as it were.
I'll do that now. Right, flexor tendon retrieval. The first thing to note when examining a hand is what position was the finger in when the injury happened, say it's a laceration, because there will be a difference to the proportion of the tendon stumps either end, according to whether the finger was in extension, as in this top picture, when the finger's out straight. So when you put the finger onto the table, as is shown in this picture here, when you bend the finger in surgery, the distal stumps will immediately come out of the wound because the finger was straight, so the full length of tendon was already in the finger. It hadn't been pulled short. Whereas, so actually, if anything, it's going to be the proximal stumps which will have retracted up into the palm. Whereas if a patient's grabbing a knife whilst the finger's cut, the finger's flexed, well, they've already pulled a lot of the tendon in towards the palm at the point where the cut is then made. So, sorry, yeah, with an extension wound, you're thinking about making your Brunner's incisions in a proximal direction from the laceration. Whereas with a flexion wound, because the distal stump is likely to have shot down towards the tip of the finger, particularly when the finger's out straight on the table, then you're going to be thinking about making your Brunner's incisions in a more distal direction, and the proximal stumps will be closer to the wound. The first thing to do is, as far as trying to retrieve a tendon, the first thing I do is a tenodesis. So if I'm forcefully flexing the wrist forward, and I'll also then bend the finger affected forward, and I'll see if the tendon stump, the proximal tendon stump, which is the one I'm really after, will reveal itself in the wound. Because if it will, then I'll quickly keep it in place by putting some hypodermic needles across between, so through the tendon stump into the flexor sheath or the surrounding soft tissues, to hold that stump there so that I don't lose it, because then I don't need to do anything further. That's great. I can do my repair. Otherwise, well, there are lots of tendon retrieving instruments. The Carroll tendon tunnel is the one you see in the middle here, is one of the more common. But really, I pretty much only use these in bigger tendons, like retrieving from the forearm or elsewhere. In the hand, I find these too big myself and too bulky. I might use a hemostat, and what I will tend to do is I will put a hemostat 2 or 3 times down the flexor sheath, maybe up to the jawline, not really much further than that, just to see if the stump of the tendon is just there within reach and I can pull it into view before putting a hypodermic needle across to hold it. And if I can, then that's great. I don't need to do anything more because I've retrieved the tendon end. But you don't want to do too much of that because you can cause collateral damage. So if 1 or 2, maybe 3 times, if more than that, and I think you've got to start thinking about some other form of retrieval. So the most common is to then go to the palm, make an incision at the palm so that you can find the tendons. You then retrieve the lacerated end of the tendon, has been shown here, through that palmar incision, and then you're going to pass a feeding catheter down from proximal to distal, as you can see here, to which you're going to tie the ends. The problem with pulling the tendon out into the palm here, do you see there's a little blush of red on the tendon? That's where the vincula was holding it in place. By pulling it out into the palm, you have now ruptured that one little vincula that was still remaining attached to the tendon and actually was preventing it from completely retracting. So you've now ruptured that. So you've actually done a little bit more damage to the finger. So it isn't my first choice of treatment, but it's the most commonly used, so I'm showing it. And then you pass your tube, a pediatric feeding tube, or I actually use a cholangiogram tube, down the finger from proximal to distal, and then you're going to tie the end of the free end of the flexor tendon onto the end of that tube, and then you're going to pull the tube out through the palm, and with it should follow the flexor tendon into the zone where you need to repair it, and then put your needle across to hold it in place. If only the FTP has been divided, you need to remember to pass the tube between the 2 slips of the FDS. If you go down one or other side, it causes massive bunching and the tendon won't run nearly so smoothly, and it's got to lie deep to it afterwards. So you pass it down and along. Then you are gonna, another technique for doing it is actually to use a looped wire, dental wire. If I have already got the tendon end out in the palm, then I'll put a little stitch through the tendon end. I'll put the wire through, and then I put the end of the stitch, which has got hold of the tendon end, into the wire, and I'll just simply pull the wire back out. That brings the stitch with it, and with pulling on the stitch, you should be able to pull the tendon into view, and then you can do your repair into in the site of injury. My actual preferred technique is to, when I've gone to the palm, is to not pull the tendon ends out, but in fact to pass a catheter through from proximal to distal. So it's going along the edge of the tendon. Then at this point, so you've now got the tendon with the tube lying directly next door to it, which I've passed from proximal to distal. I then tie a special pull-out suture between the tendon and the tube. So they're now tied to each other, and I can pull it. When I pull on one end, it will undo. The catheter is then pulled through until the end of the tendon comes into view, and at this point you want to put across a little hypodermic needle to hold it in place, and then, because the knot is actually probably underneath the A2 pulley, obviously you can't leave that there, and at the moment the tendon's attached to the catheter. Because it's a pull-out stitch, I can pull on the stitch and that will detach the tube from the tendon, and I can then pull out both the stitch and the catheter. But sometimes if it's very heavily scarred, then you've got to just open up the whole finger, and you've got to try and preserve the A2 pulleys as possible and try and thread the tendon back underneath the pulleys, trying where possible to preserve the A2 and the A4 pulleys. Thank you very much.
Thank you, Tony. I will plan on having a Q&A session after the next talk. So if we could go to our first talk by Sarah Griffiths, our therapy colleague, and I think to all of the participants, we're hovering around the 300 mark. I can't stress how important therapy is when it comes to all of the stuff you're going to be hearing today. So please do watch this. Thank you.
So with regards to zone 1 and 2 flexor repairs, we've got to consider the tendon glide happening. It's important that we keep things moving to keep that glide, but we don't overstretch it. So we manage them with a splint. We put them in a dorsal blocking splint, and with the zone 1 and 2s, we just need to keep them in a short splint. It allows your wrist to come back to 45 degrees of extension and allows you to get a better tenodesis effect. So you can come back to start your exercises, and you can come forward so you're not overstretching on your flexors as you come back into your extended position. That tenodesis effect gets your tendons gliding over each other better, and you get a better curl and better wind up from it. With these injuries, swelling's a problem, scar tissue's a problem, so it's important to keep the joints supple and to keep the soft tissues at length. So it's always important to teach people to give a good passive stretch, working all the way into a composite flex position on all their fingers. People like to exclude the injured finger, but it's important to make sure you're getting a good wind up of all of those. Start with passive flexion to get everything loose and supple as possible to start with, to get a better chance of getting a tendon glide after. Doing 10 stretches of each finger before you start your active exercises, but we're looking at doing these exercises hourly, so that you're doing little and often and you're not making them swell up massively by overdoing it straight away. So passive movement's important to start with, so that you're keeping the joints supple, you're loosening the soft tissues to get a better effect of the tendon glide afterwards with your active movements. We do 10 repetitions of passive followed by our active exercises. We don't want to do so much that everything balloons up and becomes really swollen, but we want to keep it supple. We're working on passive, coming all the way in and then fully down into a composite position on each of the fingers. We do them individually because otherwise they tend to stop at the first point of it hurting, so that we keep all the fingers moving. It's important to include the unaffected fingers as well to start with, especially because they all stiffen up after being in their post-op dressings. We then look to do their active exercises. Now, what we want to do is use that tenodesis effect of the wrist from having the short splint. So we let them come back into their extended wrist position, and then they're going to curl their fingers down all together and then roll down into a fist as best they can. When they then go to extend, we encourage them to flex their wrist forward and extend up to the hood of the splint. The splint stops them at about 30 degrees of MCP extension. And then they can do the same again. They repeat, they bring their wrist back and they curl in. They generally don't move this well, so we try and get them moving as much as possible. If they're really struggling, you can block in the palm and get them to touch down to the tip of your finger and then come away from it again. And then you can grade it coming down weekly, just to encourage them to get a curl from the fingertips and get a good differential glide of the tendons. At the end of week 1, you'd aim for sort of 3 finger width would be a successful sort of starting point to curl, to try and make sure they're rolling down to that point and coming away from. It's against, the work of flexion is important, so there's the least stressing possible, so you're just working against air and you're not putting any resistance behind it. So don't let them grab anything, don't let them use it for those sorts of things. Just to protect on that tendon repair as much as possible. So with the short splint, what we can do is get a tenodesis effect. So you're adding in early tenodesis of trying to get that position and that pull through the tendons at your wrist level. It also allows a better position at your MCPs. So we know that bringing your MCPs out a little bit further allows a better glide and a better tendon glide than having them further flexed as they used to be, and using more of a lumbrical action to start the movement. We also know through research that we've done and evidence out there that we haven't had an increased rupture rate with bringing them out to this point, so it's been safe to do so. We also, in between exercises, we tend to rest them to stop patients resting in a flex position and getting contractures of their joints, we allow them to come wrist forward, straight into the top of the splint as best they can, and then the strap just holds them there. It's not there to yank the fingers back, because we don't want them pushing back on their fingers, but it just allows them to rest a little bit straighter and try and prevent any contractures of the PIPs. So at 6 weeks they come out of their splints. They're very grateful for that, and they're allowed to now work through full range as much as possible. If they end up being resting with a bit of a contracture, we put them in a splint to stretch them out. Otherwise we want to try and get them moving fully and as much as possible. Everything's free to move, the wound should be healed, they should have done the scar massage, and they can start using for very light activities like brushing their teeth or picking up some paper and things like that, but still no heavy resisted work on that tendon. That continues for another couple of weeks, and after about 8 weeks they can start gradually increasing how much they're doing until the 12th week, where we don't limit how much resistance goes behind that tendon, and they can try and use it for full function. So for zone 3 or more proximal, they go into a long splint. So the angle's difference is the wrist is in a neutral position and the MCPs are still coming in at about 50 to 70 degrees, but a little bit more flex than they would in a zone 1 or 2. Otherwise, the exercises are very similar to the zone 1 and 2. The difference really being that your wrist is immobilised, so you're not having that tenodesis effect on your wrist. The exercises stay the same, so you're still going to do your passive stretches of each of those fingers all the way in, and you're going to work these each hour to make sure everything stays nice and loose, nice and supple, and keeps moving. You're then going to do exactly the same of doing your flexion exercises actively and bringing them in as best you can, and again extending up to the hood of the splint. So the difference just being that you haven't got that mobility of your wrist and that tenodesis effect at that point in time. Again, we have the strap that we just put on for in between exercises just to stop them resting more flexed. So with the evidence that we've got at the moment, we haven't got evidence out there to say that we're safe to bring them out to a greater extended position. So we've kept them at about the 50 to 70 degrees mark to prevent rupture. With the short splint, you stay in the same splint all the time, the exercises don't change. With zone 3s and more proximal, what we do is we start a wrist tenodesis at 2 weeks, just to make sure we're getting a bit of a glide. So the patients will be told to take their splints off to start that exercise. So they will be taught to come forward and let their wrists come forward and let their fingers extend. And as they go backwards, they relax their fingers and take their wrist back to get a natural tenodesis. Now, initially, when they're doing that at 2 weeks, they only start that twice a day, and they only do about 5 repetitions. And then they work from 4 weeks to taking the splint off during the day and when they're safe, but wearing at night up until 6 weeks down the line. Progression then after 6 weeks is the same as zone 1 2s with time scales. They're gradually allowed to do a little bit of light function, light use, building up again until that 3 months down the line when they can return to full functional use of their hands. The difference really for FPL is position of the splint and how you're protecting the tendon. So again, you want to take the tension off and not allow them to overstretch, but we're not looking at trying to cause a contracture from MCPs and IPJs. So we bring them more round into an opposed position to take the stress off, and then we'll still do the same exercises of flexing all the way down passively, letting them actively extend to the top of the splint, and then actively bending down again afterwards. So exercises remain the same. The wrist tenodesis is the same as the long splint on the zone 3s and proximal. The only difference is the change of position. Your fingers are kept free to keep moving and mobilising. We treat the FPL all the same with the zones at the moment, so they're all managed in the long splint.
Thank you very much. I think we'll try and do a quick combined Q&A session, if that's okay. So if we can go back to the previous session, as it were, there's a good question about WALANT, which is, well, there are 2 questions actually, but they essentially can be covered in the same. Is what are the contraindications to WALANT? And there's been a specific inquiry about sickle cell patients.
Contraindications are where you're basically worried about the circulation. So your sickle cell is interesting. I'm not aware of it causing sickling, but maybe that's just because we just don't see many sickle cell patients in this country. So I can't answer that for sure. I don't see why it wouldn't be a problem. I imagine that you use adrenaline in local anesthetic on sickle cell patients in other parts of the body without it being a problem. But maybe one of our panelists from Africa can answer that. But only if there's a concern about the circulation in the hand do I veer away from using WALANT. And certainly anticoagulants isn't a reason not to use them, because the adrenaline normally stops the bleeding anyway.
Thank you. Wee Lam, you look like you may want to say something.
No, I'm just wondering whether Samuel, do you have an answer for that?
Can I come in?
Sure.
Yes, please, Dr. Nungu, please do.
Yeah, we have been our anesthetists are very reluctant. Our anesthetists have been very reluctant to use adrenaline in sicklers, on patients with sickle cell disease. So we are very, very restrictive using it in patients with sickle cell.
Okay. So possibly there is a contraindication or a relative contraindication. I wasn't aware of that.
There is a case report.
It's a relative contraindication.
There is a case report, a single case report in JPRAS. So I don't think there's much else reported in the literature. Sometimes in patients with sickle cell anemia, we hesitate to use a tourniquet. Because
that's true.
So you can argue WALANT is actually a good indication to avoid the use of tourniquet. So I think we're not too clear about this. We have to look more into that. Contraindications to WALANT, I will hesitate if the patient has any vaso-occlusive disorders, Raynaud's phenomenon, Raynaud's disease, any sort of circulatory distal digit problems. If the patient is uncooperative, these are the main contraindications.
Thank you. Anyone else want to chip in on that? Or should we? Okay, I'll move on to the next question, which was also a nice broad question, but partly because I remember this from when I was a student. I'm not a hand surgeon for those for the attendees. The quadriga effect. Could somebody just quickly go over that?
There's two parts to it. There's quadriga and then there's lumbrical plus, and they often slightly interchange between the two. I mean, the true quadriga is the fact that if you put in the FDP too tight in one finger, because they're conjoined, by the time that finger hits the palm, you can't pull in the others because the tendon, the muscle is sort of running out of it, the amount that it can pull in. But then, and tell me if I'm wrong here, Dave, because there's lots of debate over which is which. But the lumbrical plus is what I was describing, in that if you've got a difference in the length of the FDP of the portion distal to where the lumbrical is inserting, that such that the lumbrical origin isn't in the palm, but it's actually moved with the FDP tendon more proximally, then you're going to get a pull on the lumbrical tending to extension in that finger, so that in fact with the lumbrical plus, it's the finger that has the problem is the one that can't come in so quickly. So it's actually kind of a slight reverse of a quadriga. But I mean, what do you think, Dave? Was that right?
I think more or less. I was going to pass it on to Sarah to comment, actually, because she's more of these. You're muted, Sarah.
Yeah, sorry. I'd say with the quadriga sort of effect, it is just that tension. So the times when we tend to have a problem is more when there's been more of a trauma and a loss, and the lengths then get are not right. So they have that quadriga effect, and they don't get that pull through to the same extent, more than we see the effect of a lumbrical, is what I'd say. In practice, that's what we tend to pick up on.
One thing I would say about the lumbrical plus is, and I forget to do this sometimes, if you're, for instance, amputating the distal phalanx, you really should, on the same finger, go and release the lumbrical in the palm, because otherwise that FTP tendon will retract, and you'll notice with people who have got amputations, they sometimes can't get the fingers right the way. They actually lose some of the flexion at their MCP joint as well. They can't get all the way in, and that's actually because the FTP tendon's retracted and the lumbrical's still trying to extend the finger. And now it's got the full power because there's no FTP whatsoever. It's all going through the lumbrical, and so it actually can reduce the curl up of an amputated fingertip.
Yeah, I'd agree with that.
Thank you. Can I? There's a nice question about therapy here, and Sarah, thank you very much for joining us. And it's the question is basically, when is the right time to start therapy? And for me, it always seems like a week before the injury.
Yeah, so we tend to leave it a couple of days. So we start it preferably around 3 days post-op. We want that sort of acute inflammatory post-op swelling to settle just a little bit, just to reduce the work of flexion that you get from having the increased sort of swelling that's there. But getting in before everything starts sticking or becoming a little bit sort of mushy on the repair side of things. So it is about getting in there as early as possible with it as well.
Thanks, Sarah. We'll move on in a second, but there's been a question as well. WALANT and replants.
Yeah, one of my colleagues has done a few. So Jason Wong in Manchester has done, I think, at least 2 replants under WALANT. I'm not that brave, but what he says is that by the time you get down, once you've fixed the bone and you've cleared everything, the adrenaline's starting to wear off. And so actually it's perfectly possible to do the arterial anastomosis without any problem. I haven't been that brave yet, but it's nice to know it's doable.
I've not done a full replant, but certainly revascs under WALANT, and actually the digital artery is still pumping away, and you can normally put a little bit of lignocaine or something into the artery, and it seems to open up when you're doing your flush anyway. So I think it actually makes it easier possibly, and there are some papers out of China that they do a lot of their replants just under WALANT.
Thank you. I think we should move on. We're not doing too badly with time, and we're 20 minutes behind now. But if we could move on to the next session, thank you so much for bearing with us and being here. Next talk is on extensor repairs. And how I do it from David Bell. Thank you.
Extensor tendon injuries are usually left to the most junior member of the team to repair, because the tendons are easily accessible and the technique is not so difficult. However, there are a number of pitfalls which prevent optimal outcome. The first relates to anatomy. The EDC muscle gives off tendons that span 4 joints and insert into 4 digits. This means that any discrepancies in tendon length can't be adjusted for by changing the resting tone of the muscle. Any error in length will have an effect on the joints beyond and may also affect the adjacent digits. Too short a tendon and there will be problems with finger flexion, and too long and there will be extensor lag, and either may result in abnormal finger postures. Secondly, the extensors are flat and thin. They pass through a narrow space between bone and skin and need to glide. Over-enthusiastic tendon exposure and mobilization might make you feel good to see that everything is displayed, but it will increase the adhesions and inhibit glide and give a poorer outcome. Expose what needs to be exposed for adequate repair, but beware of excess. Extensor tendon injuries can be classified by zone as shown here. Note, each joint is an odd number. The thin and flat nature of the tendons means a core suture is rarely possible, certainly distal to zone 5, because the tendon is less than 1 millimetre thick. I favour this technique as described in greens with a 2-layer repair. The first is a simple running suture, and this serves mainly to create the correct length in the tendon. Lock that in, and then the second layer is a silver-skilled figure of 8 that we came across in the epitendinous suture for the flexor tendons. This provides the strength. I tend to use a 4-0 PDS for this, as proline knots can erode through the skin and may need to be removed. If the division is more oblique, the same technique can be used, but there is a step progression in the silver skilled so that the bites are transverse to the line of the tendon fibres, not parallel to the line of division of the tendon. If there is a gap in the tendon, then some form of grafting is often required. However, if there's a significant bone injury or skin loss, the tendon is likely to stick, and you may be better off leaving the tendon reconstruction until the skin is supple and the bone and joints freely mobile, especially if the repair is tenuous. The more elements of skin, bone and tendon that are injured, especially beyond the MCP joint, and the more likely you are to have a stuck tendon and a poor outcome. Occasionally you have a surprise. This lady lost her central slip on the middle finger as well as her EPL insertion, and I was planning on coming back after the flap to fix them, but her function somehow recovered and she never required this. More usually, though, a gap at zone 3 central slip needs a graft to reconstruct it, and is described this way in greens. But I tend to bring the tails together and suture them onto the extensor tendon in full extension. This is really quite strong and can be managed as a zone 3 tendon repair. More proximally, you've got many options of tendon transfers, buddying tendons and tendon grafts depending on the individual conditions and losses. Setting the tension can be a concern, and I was taught to maximally flex the IP joints, keeping the MCP joints straight, and marking the level of the transfer with the tendons as tight as possible in this position. You can then slacken off into finger extension to do the repair, having marked the level. This will give a good cascade, and if you're under WALANT, you can immediately assess and adjust from there.
Thank you very much. Shall we move straight on to the next talk, which is another talk about hand therapy, and it's to do with therapy following extensor tendon repair, which will follow on nicely from David Bell's video. So let's go on to that. Thank you. And then we'll do a quick Q&A session straight after that.
Zone 1's, Zone 2's extensor tendon injuries, classically your mallet deformity, they need to be immobilised. We don't need to worry about the glide early on, so we just need to keep them still. What's important is that you only immobilise what's required. So we use dorsal mallet splints, so we make little splints that sit on the dorsum of the finger. We then teach them how to put them on and off. So the splints need to allow your PIP to be free so that you can get good movement out of it. The important thing is that they comply and they wear them all the time. If they take them on and off and they allow the finger to drop back down, it's not going to work and they're just going to have a chronic mallet deformity. Put the splint on the back to try and get a better position. It's easier to get a hyperextended position if you're needing that, and it's easier to hold it up. When we go volarly, what tends to happen is when you're making them, the pulp of the finger can change and therefore the position can change within the splint, and they tend to end up sitting just with a slight flexion, so they don't maintain that extended position quite as easily. It's also nicer being on the dorsum so that when they're pinching and gripping, they still got some sensory input through their finger, so it makes it a little bit easier and more comfortable to wear. Depending on whether they're tendinous or bony, a bony mallet we tend to keep in for 6 weeks, assess where they're at and see if they've got any lag. If there's no lag, we wean them out. So we come out the splint and we use a bit of tape support to hold it in place while they're starting to get back going. Tendinous, anything between 8 to 12 weeks we tend to keep them in. So evidence sort of suggests 8, we tend to use more like 10 weeks because we find that at 8 weeks they'll still just drop out of it because they tend to be a bit overzealous with how much they're doing. So we want to keep them held for as long as possible. The key is keeping them on and making sure they're on properly in an appropriate way. So we tend to teach them, we hold them on with tape, and it can be any tape as long as it's not stretchy. A stretchy tape will give and it won't do what you want it to do. Tend to advise them to put them on the bottom of the roll so they've got everything set up before changing or doing anything with it. They can then lift the finger up so that it's not dropping, place it onto the tape and then pull the roll away. You can then bring it back and hold the finger nicely into it. You can then repeat that, working down the finger and again at the base. Tend to encourage them to do that twice so it's got good reinforcement, but make sure it's held. And then when they lift up, their nails should be hitting the top of the splint. So if it's just slightly away, you can always make that a little bit tighter. The point isn't to squish the finger into it though and cut off blood supply, but it's to hold it into that position. They then should be able to bend and bring their fingertip down to their palm whilst keeping their DIP nice and straight. Okay, and then they keep everything else moving. The other important thing with mallet injuries, because we're keeping this all completely still and because of the effect of your FDP tendon, is that they do keep stretching the other fingers to make sure they don't end up with any residual tightness of any of the uninjured digits. After the 6 or 10 weeks and they're coming out their splint, we do need to just assess that there's no lag. So we tend to give support, advise them to do a couple of repetitions of movement and make sure they're getting a good extensor pull and it's coming back to hold. If they still have a lag and it's not able to pull back, they stay in their splint until that lag is corrected. Otherwise we start weaning them. So we tend to wean them, especially with the tenderness, that they wear a splint for heavy function and night time for a further 2 weeks. And otherwise just a simple bit of tape support in the daytime. So we literally just bring them underneath as you would with putting on a splint and bring it back on itself, just so that it encourages it to rest straight as they're starting movement, but will allow them to actually bend and keep moving. We don't restrict how much, mainly because you can't really gauge it and stop people from doing stuff, but we just try and reinforce it and hold it for long enough to get everything going. If they find that they are starting to drop, then we need to go back in the splints and we just judge it depending on how that patient's responding. Zone 3 central slip injuries can be managed in 2 different ways. If they've been repaired, we tend to manage them in a SAM regime, which is a short arc motion regime, where we manage them in a full length dorsal splint that holds everything into extension, and they rest in that. They then have an exercise splint that goes with it. So with their exercise splint, they undo the straps and they can line up their exercise splint. Now this splint starts at approximately 30 degrees at their first appointment at a week down the line, and then each week from then on until 6 weeks you gradually increase the angle that's allowed by about 10 degrees. This then lines up really nicely and they can flex down to it and then extend up towards the top of the splint, and they can go again. The important thing is keeping that position and going back up and keeping a glide without overstretching on that tendon. And straighten. They don't do passive range of that, they're only doing active exercises, but if they're struggling to get back up to the top of the splint, they can do a bit of a passive stretch to extend it fully. The other part of it is you can have 2 splints, or you can flip this one round, is you can block DIP to really make the DIP move, and you can also do a passive stretch just through the DIP while blocking that PIP from flexing from week 1 as well. So we don't need to immobilise the DIP in central slip zone 3 injuries, but we need the leverage in the splint to hold. So it's quite nice to keep it included on these splints to get a good leverage and get a good extension, but we need to make sure they are actually moving it. So that's why that's part of the exercise. After that, they go back in and these straps come back round and hold it in place. That goes on for 6 weeks. With the gradiating of the movement, as I say, and at 6 weeks they come out of the splint altogether. Okay, perfect movement. After 6 weeks we then allow them to have full range. With extensors, the difference being on flexors is there's not as much effort that goes into work, you don't put as much resistance behind it, so we only really limit people up till 9 weeks down the line. After 9 weeks we let them do everything as normal, unless they are boxing or hitting or having a forced impact into flexion, and again we leave that for about 12 weeks down the line. The importance with this regime is compliance of the patient. If you've got a patient who has dementia or isn't able to follow instructions and isn't going to remember what they're doing, it's not the safest thing to do. Likewise, if someone had an injury that hadn't had a repair, we like to keep them completely still, and we use a little cylinder splint to do that. So the cylinder splints can go on and they just immobilise your PIP into an extended position. They're held on with a bit of tape again, and that you can bend and keep your DIP moving and free all of the time when they're doing their exercises and when they're using their hand. Light function is okay with the splints on. You're not going to do harm with just light use of your hand. We use it for 6 weeks and then we come out of it and get it going. Now again, if they can comply and they're able, after about 3 weeks we can take them out and just allow some gentle exercise movement and then back in the splint altogether to try and keep a bit of tendon glide. But we only really immobilise the patients who aren't really able to follow those instructions, because we know that with the SAM regime they have much better outcomes. Zone 4 extensor tendon injuries can be managed in 2 different ways depending on where in that zone it has been injured. If we're looking at a proximal zone 4 injury, we're looking really from a therapy point of view to manage it as a zone 5 because of the insertions of where that tendon's going in. If we're looking more of a distal zone 4 injury, then we're going to manage it as a central slip because it's having more of an effect over the PIP at that point, and we want to maintain the extension at that level. So it's really important to be clear when you're operating and what you're writing as to where in that zone the injury is, so that from a therapy and rehab point of view we can treat it appropriately. With extensors from zone 5s, we're looking at immobilising a little bit more. So we need to keep the wrist immobilised and we need to protect over the zone 5 and make sure it's not going into too much of a stretch. We follow the Merit regime, the 2-part splint, so they have a yoke splint that keeps their affected finger in relative extension to the uninjured digits. That is to try and take the pressure off where the tendon's been repaired, but allow them to have a little bit more movement. A yoke splint can be made in a couple of different ways. You can either leave them open or you can seal and close them off completely in order to hold them back. The whole point of it is to bring the finger into a greater extended position, take the tension off your extensor where it's been repaired, and therefore it won't go through such greater range as the other thick fingers as you're getting everything moving. It allows early movement, it allows a tendon glide to try and prevent those adhesions from sticking everything together, but it's just doing it in a protective manner. With these, they have both splints, the wrist into a little bit of extension and the yoke splint over as well. They're then taught 2 different exercises. They can actively curl their fingers into a hook position and straighten out, and again. So it won't go quite so far on the affected finger because it's blocking. They're then also taught to do an isolated MCP movement, coming down and coming back. The splints don't really block MCP, so we do want to get that movement because this splint is stopping that tendon from going over too stretched by holding it back as well and coming back to that point. They are allowed again to passively extend, taking tension off if they've got a bit of a lag, but they're not to passively flex on that tendon repair. That's continued from week 1 right through, but at 4 weeks we bring them out of their wrist splint, but their yoke splint still stays on. So at 4 weeks we give them a bit more freedom. We allow them to start again their wrist tenodesis movement, loosen up their wrist, get everything moving, but it's important that they keep their yoke splint in situ to again reduce the tension on that repair site. At 6 weeks they then come out their splints in their entirety and they work towards full composite flexion all the way in, lovely, and then all the way back out again, and they keep that side of things going. This is only useful, however, if you've got 1 or 2 digits injured. If you have more than 2, you can't get relative extension in a yoke splint. We then manage them in a 2-part splint. So there's a couple of ways of doing it, but we manage them in a splint that has a plate that will hold their fingers into extension, and then we'll have an equivalent splint that sits over the top. The difference being on this one is the splint that they make, not this one, but it will sit slightly higher and it will allow 30 degrees of MCP movement up till the splint, and it will allow them to hook down towards the top of the splint and back up again. After they've done their exercises, they slide this part back in and it holds everything back in extension. The reason we do that is to try and prevent an extension lag at their MCPs from resting too flexed, and it keeps it going in between times, and we've found that's worked to good effect using that part of a splint. Again, with that one, the difference being that they remove the plate at 4 weeks and they keep the wrist splint in situ. rather than just having the yoke splint on from 4 weeks. So with regards to thumb extensors, there's 2 different things that you have to manage. So this splint is for if you had an EPB or an APL injury, where you want to keep the MCP extended and you want to keep the wrist supported and preferably in slight extension, but you don't need to immobilise the IPJ. So again, talking about only keeping still what needs to be kept still and protecting everything else. So with these, we keep them in these splints. After a couple of weeks, they'll then start coming out and starting some active movement and then resting back in the splint in between times. And this splint then again stays in situ for 6 weeks. After 6 weeks, they're allowed full range and to gradually increase again up to that 9-week point of getting back to full function. The difference with regards in EPL would be the splint would just sit longer and it would support the IPJ into extension as well. Those then are taught to lift up out of the splint a little bit, to do some IPJ flexion exercises from week 1. And then from week 2, we make them a little mallet support and we start MCP movement. So they come out of the splint. What we're just trying to avoid is full composite flexion over that tendon. So we tend to use a support just to stop them, just to make sure that they're just doing an MCP movement and they're coming back out and they're resting back in their splints again after that point in time. With both of these, they'll start their wrist tenodesis as an extra 2 weeks down the line, and they'll be in their splints for 6 weeks. Anything more proximal to the wrist depends on exactly what structures are effective. If you're talking more muscular, we just tend to immobilise them for 3 weeks and then start getting them moving because of the muscle healing and get everything working a bit quicker. If we're talking about a wrist tendon, either flexors or extensors, we wouldn't start any wrist tenodesis until 3 weeks, so we immobilise them for slightly longer. If they are singly wrist extensors or wrist flexors, we can just immobilise the wrist. If they're combined with one of the longer tendons, then they're managed under the protocol following the longer tendons.
Okay.
Thank you. That's brilliant. That was we'll put some these videos on YouTube, hopefully with all of the speakers' permissions. I think that one is a really good one to refer back to. It was a long video. It's comprehensive, but I think almost everything you need to know about extensors is in there. Let's move on to a quick Q&A session, if that's all right. I think we've actually made up for some time, so we're doing all right, because my job is basically to keep us to time. So I have just lost some questions. I think there was one generic question of how long should a patient spend with the therapist? We did the sort of how quickly should we start? How long are your individual sessions, Sarah? You know, I know they'll vary, but generally, how much time is dedicated?
So they get an hour's appointment on their first attending. So when they first come in, they have an hour to have all their dressings taken down, have their splints made, and then just really a huge amount of education. So they're talked through again what surgery they've had, what the implications are, and what that means to them and their work setup. And then starting their exercises. So they do all of their exercises then in that first session before they leave. So the first one we generally give about an hour, depends on what they are. If you have a simple sort of mallet injury, you obviously don't need that long, but on more of the complex stuff. And then they come back and their appointments are half-hour long. So again, it's to tweak splints, complete their exercises and manage everything accordingly in that time frame.
Thank you, Sarah. And then this is a question from me, really. Our audience is going to be really mixed from around the globe. With, you know, not everyone will have a therapist in their hospital. There will be doctors, there'll be nurses, there'll be general practitioners, general surgeons, orthopedic surgeons. Who do you think, if you are running a department that does have surgery and being done by whoever, generically speaking, who do you think is the best person who don't have one therapist that could essentially take that role on? It's probably unfair, so don't advise to answer it, you know, fully.
Yeah, it's a tricky one. I think there's got to be someone involved who can explain what surgery they've had that can just give them the advice to start it. So I suppose that then depends on, do the nurses know enough about what they've had done to make those explanations, or does that need to come by a doctor who's actually done it, or someone who understands it a little bit more, because I think the education is really the underpinning of everything we do. If they understand it and they can follow and appreciate what they've had done, they're more compliant with it afterwards. If they don't understand the full effects of it, then you won't get them on board. So I'd say that that's probably the key part of it. The other bits are fairly straightforward. Just starting a few exercises are easy to teach anyone how to do them, but it's having that education in the first place.
So do you think it's probably the operating surgeon? Is that who you'd pick as your number one person if you didn't have therapists?
Yeah, I think I would. And I think probably the patient would take it better from them as well. They might listen a little bit more. So that probably would be where I'd go with it.
And I know that, Dave, you've answered this question possibly privately to the questioner. What's the best alternative to thermoplastic splints if they're not available?
I think it depends on what you have got available. You can make a decent POP, then as long as the position's right and you're holding it on and allowing movement, then you could use that. If you're talking just a single digit thing, if you put a Zimmer on and you put it on well, then that's fine as well. It's just making sure that they can allow the movement that they need to do and that they're holding in the right position.
Can I just ask our panelists from Tanzania what they use? Is it thermoplastic material that you guys have available for hands?
Yes, we have plastic material for hands, and they have a good number of physiotherapists because we have a physiotherapist school. Therefore, we have a good number of physiotherapists around. And whenever, or in the beginning when we had problems, we used to use tongue pressers also, could do the job for us, tongue pressers, and sometimes even invent with the open syringes. You carve in the syringe, 5 cc syringe, could also do the job. But we are using plastic material now in Tanzania, especially in the tertiary hospitals.
Is there, I mean, this is a really naive question. Is there actually a material that is almost thermoplastic that's available every day that isn't the formal stuff? Like, can you melt a syringe in hot water and mold it or something like that? Is there anything like that that's available out there that you can think of? This is me as a naive non-hand surgeon asking probably a very silly question.
I didn't get your question properly, excuse me.
I was just wondering if anyone knew of any, you mentioned using syringes. Is there anything, any kind of plastic or malleable material that you could almost heat up and make softer and almost make it behave like thermoplastic that's out there every day available?
Not to my experience, because we have plastic material. Not my experience. Probably Monday can respond to that also.
I don't.
Yeah, thank you. Those kind of materials which can be used to mold a certain shape to get a splint to fit the patients. We do have those kind of materials in tertiary hospitals, especially here in our hospital. But in small hospitals, like in peripheral hospitals, there have been a problem. These kind of materials, they are not there present. So as the Chief Nungu is saying that using of a spatula together with a cutting of syringes is kind of improvising of using the tool for splints. So another challenge here in these kind of materials, not all patients can afford because they are being prepared by not physiotherapists exactly, but those kind of people who are doing orthotics. So orthotics and materials. So if you see a patient and you think that will need to have a splint for immobilization or for whatever kind of tendon injury, especially those small ones in the fingers or the ones Sarah have explained, we have orthotics here who can make them, but there are few patients who can afford paying the cost of materials because the materials are, according to orthotics, are kind of expensive and not all patients can afford those kind of materials.
Thank you. I'm just going to move on to some of there's a couple of new questions that have just come through. Where are we? Can you treat sagittal band injuries conservatively in something called a yoke splint is one of the questions. I don't know what that is. I don't know if anyone can answer that. I can't.
Yes, you can. I find if you're conservatively managing them, sometimes it doesn't put enough hold on them. So because they still have a certain.
Sarah, could you just
just
tell us very quickly what is a yoke splint?
A yoke splint is that second splint that's slotted on with the bigger one that we were talking about for the extensor repairs and management. So it's like a little knuckle duster that sits around the fingers that holds it back with a bit of relative extension. So it will take the tension off your sagittal band, but I do find on a closed injury that hasn't been repaired, they quite often do better just sitting in a palm-based MCP blocking to start with, just to completely take the tension off and let everything settle, let it all heal, and then gradually progress them to a yoke and then out of that again afterwards.
Yeah, so the yoke, in the video, it was that loop splint, which was called a merit splint in the video, but it's actually it's another name for it is a yoke splint.
Okay, so thank you. And then I'll just again, just to keep us on time, one more question. Oh, Lamb has just started sharing his screen to show us a picture. Tell us what that is,
That's a yoke splint.
Yoke splint. Cool. Thank you. What about limitations in range of movement after splinting? Because obviously, you know, when you splint patients, you restrict other movements. There's a question of how can we get patients back on track with that?
Well, we can push it more, I think is a simple answer. Once you're not worried about rupturing repairs, it depends whether you're talking flexors or extensors and then the complications that come with that. The extensors generally do fine. You start pushing them, they'll come back, they won't have any problems. Flexors are a little bit more traumatic to get back going again, but that's why we don't limit them so greatly. They go through their full range. If they end up with a flexion contracture, they go in a splint or something to help stretch it straight and get that back and work on pulling it back. Otherwise, we start pushing them.
Thanks, Sarah. And then someone has it's more of a comment than a question, saying, you know, hand surgery without trained hand therapists will lead to worse outcomes. Please train therapists. You know, yes, I'm sure Sarah, you'll echo that. Yeah, train more therapists everywhere.
Yeah, great.
Yeah, I think that I've said it several times this afternoon, but I think the key person here today is Sarah. Actually, you know, we're all very good at surgery around the world. We all get trained really well on how to do the surgery, but it's actually how to maintain the result and make the best of the result. And I think people like Sarah are critical. Very last question, and we'll move on. Dynamic splinting, Sarah, what role does that play?
We used to do dynamic splinting for things. We've moved away from it. They're very big, they're very cumbersome. People don't like to wear them. The only thing we've really put dynamic splints on now, sort of nerve injuries where they need sort of the tension from the splint to get them back, or if you're talking about joint replacements and making sure the alignment is correct and working that side of things. But generally, patients aren't the most compliant with splint use anyway, and if you start putting big sort of dynamic splints on them, they definitely won't wear them.
Thank you. I think in the interest of time, we'll move on. Again, we're not doing too badly. We are a little bit over time, but now we're going to move on to the next session, which is when things go wrong, failed flexor tendon repair. Dave Bell is going to give us his talk on that.
Okay. Hopefully I'm not muted.
No, you're good. No, I was muted then. You're good.
Yeah. Nice. Okay. So you've done your flexor tendon repair, and then you can see the patient anytime immediately afterwards or months down the line, and that tendon's not working. So this talk sort of helps analyze what's gone on and what to do about it. So first of all is if the tendon isn't working, well, why do you want to do any more anyway? You have to you have to analyze exactly what's going on, and if the patient isn't functionally impaired by this tendon not working, then all you're going to do is take them out of the workplace for a little bit longer and have the potential of making things worse for them. However, if you decide that you are going to do more, there's a sort of a rickety ladder that you can consider of doing things. So we've talked about no further surgery. It may just be that the tendon's not ruptured, but it's actually stuck. And so you might be considering a tenolysis. You may decide to completely bypass the tendon and just bring another working tendon in as a tendon transfer. And then Tony's going to be talking to us about stage 1 and stage 2 tendon grafts. So if the patient comes to you and it's relatively soon after the operation, the most likely thing is that your tendon has, the tendon repair has ruptured. If it's a little bit further down the line and there are other things going on, I suppose the consideration is that the tendon may be paralyzed, and so therefore it's not working from that point of view. But more usually, the tendon will be stuck somewhere, and it'll either be stuck to the pulleys or it will be stuck to the other flexor tendon. The way you can tell between the two, I mean, it may be both, but the way you can tell between the two is if it's just stuck to the other flexor tendon but not stuck to the pulleys, you're going to be able to get some flexion in, but it won't be the full range. It'll maybe half of it. But then passively, you can then take it and take it the full way in. If it's stuck to the pulleys, you may not be able to move it at all, and you'll see that there's effort, and the tendons in the palm may be sticking out a little bit, and you see it's trying to do something, but it's not able to go very far. If when you flex it in, if when you try and passively flex it, there's nothing going on at all, well, one of the reasons could be that the joint is either stiff or the joint is blocked. And particularly if you've had a patient with, say, an infection, and you're now months down the line and you're seeing them and they haven't had much in the way of rehab, then actually you've got to worry about these secondary changes in the joints. And then the other thing that often gets overlooked is it may actually not be the flexor at all, but it may be the extensor that's stuck. Because you've got to remember, as the flexor pulls, the extensor pays out rope. And if the extensor can't slide forward, then you're not going to be able to flex the finger in. And so often, particularly with wounds to the back of the hand where there have been skin grafts, then actually that is your most likely candidate for why you're not getting good flexion. So tenolysis. If you're considering doing a tenolysis, you've got to think really what stage are you at, how wide a zone are you having to dissect, and how likely is it that you're going to be able to get to the bottom of it. So in terms of the mechanism of the injury, if the hand's gone through rollers and you've got a crush injury from fingertip to mid forearm, then you're going to have a very wide zone of adhesion likely within the tendons. If you've had a very narrow crush or a cut, it may just be stuck in the very, very narrow band of injury. Motivation of the patient, whether zone 2 is involved, and the host biology are other things to consider. But before you start, you've got to be working with your therapists. Have they got to a plateau? Are they still saying to you, no, we're getting a further range of movement or a further range of movement? How good are the joints? Is the skin supple? And then the big question from a consent point of view and a planning point of view is that actually doing the tenolysis occasionally ruptures a tendon repair. So what are you going to do then? Are you going to then proceed to re-repairing it and then go into all the splints and all those things, as well as having a big raw area that you've now created, having done the tenolysis? Or are you going to go down a tendon reconstruction route, or what are you going to do? You need to have a plan for that before you start, so that if it happens, you know exactly what you're doing rather than panicking on table what happens next. Because the other thing is that if you're doing a tenolysis, your therapy afterwards is immediate movement. If you're needing to do anything else, then you've either got to think about, you've really got to think about your timings. So if you're doing a tenolysis, wait a minimum of 3 months, maybe a bit longer if it's a tendon repair. I try and do these under WALANT where I can, because it's just so much easier to address the issue of you can actually see where it's sticking, and you think you've released everything, and then you get them to flex and they can't flex. So WALANT is brilliant for tenolysis. If you've got a very long zone and you think you're going to have to open up the whole finger, you might consider doing the Samet technique, which is where you open up the finger, you come to the side of the pulleys, you lay open the pulleys from a lateral incision all the way open, and you lift the whole lot open as a book. Gives you good vision to all the tendons. You can unstick it, and then you stick the pulleys back down again. I've tried it twice. I've never got it to work, because generally in those cases what you're left with is that the pulleys are really, really thin, and you end up not having anything left to stitch. So you're often then in a situation there of going, well, I've got to do a tendon reconstruction and a two-stage graft. I like, for small zones, zones of adhesion, I like this loop technique, and I've got a little video of that now. Hopefully it'll work seamlessly. This is a tenolysis model. This plastic tube represents the pulley system, and the tapes represent the pulleys. The yellow acrylic rod is a tendon, and it slides freely down inside the pulleys. If you want to do a tenolysis, imagine opening the pulleys at each end. Pass an infant feeding tube down between the two ends, and then take a 3/0 Proline and pass that down the middle of the feeding tube. Take the Proline out of the open end, pass it around the tendon, and then back into the end of the feeding tube and slide it back up. If you need a little bit of extra lubrication, some saline works well here. Once you see two suture ends, you can use a clip and clamp it off, and then if there's no obstruction, when you pull on the suture, it will slide freely along the sides of the tendon within the pulleys and come out. Here we've done this again, and you can see the suture passing around the tendon. On this occasion, when we pull it, there's a problem, and the suture loop impinges on the obstruction. By looking down the pulley, you can see where the problem is and deal with it. So if you've got an intact FDS, you've got to think very hard about whether it's worth doing any more, because how good are you really? If you look at this graphic here, this is the range of movement that you get with finger flexion with the FDS and the FDP. So if you look at that, zone 1 is where or the thing that's indicated as 1 is where your MCP joints flex, and then zone 2 is where your PIP joints flex, and that tiny little area, zone 3, is the bit that you're going to gain by giving them an FTP in the absence when you've got a fully working FDS. And similarly, if you've got a hook position and you're bringing your fingers in, then the only difference is the line of P versus the line of S. So if the FDS is intact, the patient must really have to earn why you're going to do a reconstruction, because it's so much easier to make them worse. One of the things might be that they're very young, they've got a very, very hyperextensile DIP joint. But frankly, if you've got that, why aren't you thinking of doing an adhesion? An arthrodesis. So sometimes we get into the mindset of there's a tendon that's been injured and therefore we need to fix it. So arthrodesis, particularly for the DIP joint, is very good, and you can use a number of techniques. The pictures in the top right are from the internet and are of cannulated screw. I use that quite a lot as a technique, but I don't bury it in quite as much as the images shown there. Two other good techniques are the Lister loop, which is the top left, and tension band wiring, which is sort of the bottom two images. And then occasionally you might consider amputation if somebody has got a very damaged soft tissue or loss of sensation. But otherwise, that's me done, and we're on to tendon grafts.
Thanks, Dave. So are we moving on to therapy when things go wrong?
Yes, we are. Sorry, yes. Give us a second.
I'm just trying to see. I think we've managed to, a lot of the questions on the Q&A, just in the interest of time, we've hopefully answered them directly in the chat. But if there are other questions, please do send them through. And okay, so therapy when things go wrong.
How would you advise somebody if they'd had an isolated FDP injury that had ruptured?
If they'd ruptured, I'd first want to know why they'd ruptured. Is it because they've got to return to work? Is it because they've done things they've not been able to, or have they just been a bit unlucky? Before considering anything, it's also important to know how supple the joints are. If they've had one lot of surgery, they're bound to have a certain amount of swelling, a certain amount of scarring. And if they haven't kept things supple, the likelihood of immediately going back in and either re-repairing it or looking at reconstructing it will be dependent on how supple the joints are, how well things are moving, and what their scarring is also like. So it's important to discuss those factors with that patient and know what they want to achieve long term. If they need to get back into work, then re-repairing it might not be the best option, and we have to then think about whether an arthrodesis is a better option if they've got a good functioning FDS, or whether they want to commit to going through another sort of 3-4 months of therapy and rehab after their surgery, or if it was a reconstruction and 2-stage, a lot longer process of recovery.
If we take the situation where somebody has had a zone 2 flexor injury that's ruptured after a week, so all the wounds are fairly fresh, what would you advise? What would push you towards early re-repair, or what would push you away from that?
It's considering really with your patients how compliant they are and how much they're willing to participate. If it's early and we've picked it up early, it should be straightforward to go back in and re-repair it. So they're not been delayed. They haven't already gone through quite a long period of rehab, and it would be starting over again. And if it's just that they've been unlucky and they say that they've followed everything, I'd probably encourage them to try. But if it was the fact that they couldn't follow it, they didn't really understand what they were getting involved in the first place, and they've gone back and they've used their hands too much, then it's really considering whether it's the right thing for them to do, because they're probably going to rupture again if you go back in and re-repair it.
What happens if FDS and FTP have gone? How would you advise?
If they've both gone, it massively affects their functional use. So that has bigger implications. They'll only ever have that lumbrical movement, and it has a knock-on effect then for the rest of the hand and the rest of the hand's function. So I'd really be educating them more and saying that it'd be beneficial for them to have it repaired, but really making sure they understand the follow-up from that, and maybe a timescale. If they're talking about having it but they can't have it repaired at the time because of work, then maybe we need to think about delaying it and doing a 2-stage later on, when they can take time off work or they can follow their instructions.
If somebody comes back having ruptured, say, late at 5 weeks and everything's swollen and a little bit rigid, what can you do from a therapy point of view to improve the quality of the tissues and the flexibility of the joint? How would you approach that?
If they're that far down, you'd be looking at really trying to get on top of the swelling. There'll be a certain amount of swelling and they'll need some sort of compression to help the swelling come out of it. If their scarring's thick and they haven't been doing any scar massage, they need to go down that line of things to really get everything supple from those point of views. They then need to make sure they've got very good passive range. If they haven't got good passive range and they can't get through that movement, then there's various tools and things that we can use to get that. Whether it's using the wrap that we use for swelling and wrapping and pulling the hand down and doing it as an active assisted exercise, whether it's using splints to get them in a good position. We use gloves as well to pull them down. So they've got to get the joints supple and the soft tissues at a good length to then be suitable for having something further. So we'd be doing lots of education as to following all those instructions, but also making sure they do it. If they're not following and they're not able to do that, they're unlikely to follow again after their surgery and do what they need to do to get a good outcome.
Are there any other modalities that you use?
So we do use ultrasound. We use it as an adjunctive therapy just to try and see if that would help soften the tissues. There's variable evidence out there, but the idea behind it is it gets the tissues mobile and moving slightly at a higher frequency level to then allow them to get better glide. Like I say, the evidence is variable. even if it was more placebo and the patients then follow it, then that's still a positive outcome. So we can use it as an adjunct to everything else that we're already doing.
If you're giving patients advice regarding stretch, can you talk me through exactly what you would tell them to do? How would you teach the patient to passively flex a PIP joint?
So there's a couple of ways. It really depends on what's stopping that PIP from moving. It depends whether they've got extrinsic or intrinsic tightness, or whether it's just solely within the joint itself. Generally with these patients it tends to be tightness rather than joint restrictions, but it is important to give a stretch. So there's two ways to do it, and it's to make sure that with MCPs extended that they can get in and get a good stretch and get PIP and DIPs flexing. But it is also important to bring it in and do both, so you get the composite movement to stretch from an extrinsic point of view. If they're not getting there and not doing both, or things are tight, that's when we can bring in splints to block and make sure they're working over it. So quite often people will do all of this, but actually the problem they've got initiating that tendon glide is that their intrinsics are too tight and they can't get that movement. So we have to consider blocking their MCPs in order to get a good stretch over the top of it. So they can hold it, but sometimes they struggle. And if we are reviewing them and you're able to give splints out, we can do splints to block their MCPs to then curl over the top of. They can also then use that after doing their passive to try and actively get a bit of movement happening as well.
Thanks very much. A few random hand pictures in there just to add a bit of colour to otherwise a face-to-face interview.
No, thank you very much, Dave, and thanks, Sarah, for that. And I think we'll now hear another take on the same topic, really, from Anthony Barabas's point of view, and then we'll move on to therapy after tendon reconstruction, which may actually answer one of the questions that's currently sitting in our Q&A box. Thank you, Tony. And you're muted, I think, Tony. Still muted.
There we go.
There we are. Yep, I can hear now.
Thank you. Sorry. Right. Right. Flexor tendon reconstruction. This is going to be a bit of a sprint because there's quite a lot to cover here in the time provided. Can you see this talk? There we go. So primary, we've done that. Secondary tendon, but we've talked about, Dave's talked about that. So we're looking really at tendon grafting, be it as a one stage or a two stage. Well, Pulvertaft initially said that to consider a single stage, you've got to have a hand in a good condition, no extensive scarring, nearly or a full range of motion, good circulation, only maximum one digital nerve injury, a cooperative patient, and really shouldn't be in children under the age of 3 for rehab purposes so that they can actually do the exercises. So indications for a single stage, so if you're going to go straight to doing a graft, would be a double level injury, so segmental loss of a tendon, early injury where a primary repair isn't possible, such as a double level injury, late injury where the pulleys haven't contracted or there's minimal scar. If in the rare in this country, but maybe not so rare abroad, in the possibility that the patient really cannot return for a second stage, and there's got to be good soft tissue cover. So Boy's classification of a finger, really you're only looking at the grades 1 being the ones that you consider to do a tendon graft. So it's good, minimal scarring, mobile joints, and there's not 2, 3, 4, 5, which is scarring or joint damage or nerve injury or multiple injuries. So you're a single digit really in a good condition. Well, your choice of donors is determined by the availability, but also by the length of tendon that you might require. It's got to be thick enough to withstand the forces of flexion, but thin enough that it can become revascularized. Because actually, if it's too thick a tendon, as that short talk on the vascularity showed, there is a component to the tendon which will be avascular centrally if it's too thick. So it actually necrose. You've got to be able to allow the fluid around it to revascularize and fluid to get in there. And there shouldn't be a significant loss of function from the tendon that you harvest. So palmaris is the most common. You can do it by this technique, which is by putting up a tendon stripper, which will detach it at the musculotendinous junction. This is certainly one way of doing it. I actually will often do a step ladder technique and make little incisions along the course of it. It should give you roughly 13 centimeters is the average. I in fact did one yesterday and it was 15 centimeters. It's absent in up to 20% of the population, so you can't do it. In fact, I haven't got one on either hand. It's normally the same for palmaris, that if you haven't got it in one hand, it's not on the other. And it's normally only long enough if you're going from the tip of the finger to get to the palm in the middle ring and the index finger, but the little finger and the thumb you might be able to get to do your proximal anastomosis in the forearm. Plantaris is another option, so it's found on the medial aspect just anterior to the Achilles tendon. A tendon stripper is what I would tend to use here rather than the step incisions, but you still can do step incisions. It's just harder, it's a bit deeper at the proximal end. That releases it at the musculotendinous junction, and this will give you a much longer length of tendon graft to play with. It's present in most people, so it's only about 10% of people that haven't got it, and in that 10%, a third of them will have it on the other side, so it is worth looking at the other foot if they haven't got it, and it's irrespective of their palmaris, whether they've got a palmaris or not. So 30 centimeters are what you can get, and you can divide it into strips because of its length, so you can do a proximal anastomosis to a single tendon in the palm, and it could splay out to multiple fingers via multiple slips because of the length you can get from it. If that's not present, then you're looking at getting a toe extensor. You've got to take the second, third, or fourth, because there isn't one to the first, and the one to the fifth tends to be fused with the EDB tendon. So second, third, or fourth, I tend to go for the fourth toe, and little stab incisions along the way, and you will find that it's quite difficult to get out around the ankle itself. It seems to be sort of quite stuck down in that area. Do the distal attachment first. There are various techniques. You can do the button technique. That's particularly useful in kids, particularly because at the bottom one, the bone anchors, one, you might not be available, but you've got to be careful about the joint growth plate in kids. You can probably put it distal to it, but the size of the phalanx might not be able to accept it. If you have got a bit of a stump left, then you can try and wrap that around the distal part of the graft and attach it in. Another technique which gives a little bit more versatility, because you could do this is after you've done the proximal repair, but is to do the through the pulp technique, because you can do some adjustments to it. Most people will have still stitched it to an FDP stump if it's there, but you could go back and just make that final decision about when to secure it, what length to secure it by a mid-lateral incision, as seen in the middle picture, just by doing an adjustment later on. Otherwise, you tie it to the back of the fingernail and it gradually just sticks down to the distal phalanx and the soft tissues there. The one thing that patients don't like is it causes a little dip and a sort of sensitive point on the end of the pulp very often. So I use the Pulvertaft Weaver, which is a sharp pointed instrument, which you can push through the tendon. This is for the proximal end. Through the tendon, and then you can grab the graft and you pull the graft through the tendon end that you're going to secure it to, and you want to change the directions. It should be about 3 or 4 passes, but you don't want all of the passes of the tendon of the Pulvertaft Weaver to go through the fibrils in the same direction. You want to ideally change the angle by about 90 degrees with each pass, so that it can't just cheese wire, the graft can't just cheese wire through the proximal stump. And so you pass it through, and at the end I tend to do a little fish mouth so that it can wrap it around and tie it onto the graft, so that there's less of an edge to catch when mobilizing. And as you can see here, with about 4 passes going through to a proximal stump in the palm. So it's more secure than an end-to-end, means you can do really early active motion straight away. And you want to do at least 3 or 4 slits through the tendon that you pass it through. Other things you could do if you could do immediate 1-stage reconstruction, you might, if you've got a missing portion, be able to do an interposition graft, anything from between up to 2, possibly as much as 5 centimeter defect. It is possible. You could do tendon transfers directly, so you could put a superficialis transfer or an enter-side FDP. They're all possible. But otherwise, you're looking at doing a 2-stage reconstruction if the 1-stage is not possible. So patients with poor sensational vascular impairment still remain not good candidates even for a 2-stage reconstruction. And you might, in severe cases, want to consider arthrodesis or amputation, as otherwise they'll end up just with a very stiff finger, possibly painful, and may affect the other good working fingers. So the first stage of a 2-stage is you've got to do a full exposure of the sheath. You've got to clear out any of the scar tissue, try and leave as many of the normal pulleys available as possible, but certainly the A2 and the A4. With the FDS, if there is the stump of the campus chiasm left there, or wherever level that the FDS is divided, you want to leave the chiasm in place, because that is going to prevent hyperextension of the PIP joint by acting as almost like a volar plate in front to stop the finger bending backwards with time. The FDS is removed back to FDP, sorry, you remove back to the palm, but the distal stump, you want to leave about 1 centimeter left, because that's what you're going to attach your silicone rod onto. As I said earlier, you try and remove the lumbricals to prevent lumbrical plus, particularly if they're scarred. If there's yeah, well, this is talking about the hyperextension again. You want to try and prevent hyperextension, release joint contractures. You try and correct everything that's wrong at the time of the first procedure. So prevent the hyperextension, prevent joint contractures. You're then going to put in the rod, and the rod is actually going to form a pseudo sheath around it, through which the new graft at the second stage is going to lie. You try and put in the largest silicone rod as is possible. You can get tapered rods, so they start thin and gradually get thicker, and you basically pull the tapered one until it gets a little bit stuck, and then just pull it back a bit so that there's enough room for a bit of movement. The rod you suture to the distal 1 centimeter stump of the FDP that is remaining. The proximal end you leave free, either in the palm or in the forearm, depending on where you think you might get to do your repair. And if necessary, you have to reconstruct the pulleys and the sheath over the top. Then the second stage is not determined by the time or the calendar, it's the state of the finger. Once the scars have all healed in, you've got to get the patient still flexing their finger to keep all those joints nice and supple, wait for the inflammation to all have settled down. And once that's all done, you can move on to the second stage. So you want, as I've just described, mobile joints, good skin over the top. I'll open the old incisions. It's not going to be all the incisions at this stage, just distally where the rod is inserting onto the distal phalanx and the proximal end. Then you're going to replace the rod with the tendon. I tend to replace it distally and pull out the rod proximally, because you're putting it into the tightest part of the finger, and it's going to get gradually more spacious as it moves up. If you do it the other way around, then sometimes the graft can pull off the end of the rod, and you've lost it inside the finger, which is a problem. So do the distal attachment first. The DIP, yeah, you obviously, you know, if when you test it and the DIP is catching, then ideally you want to try and redo the anastomosis of the graft to the stump more distally, rather than undo the A4 pulley, or at least only open a little bit of the A4 pulley if it's catching there. You want to try and leave that A4 pulley in place as much as possible. The proximal tenorrhaphy, then I use a pulvert after weave, as I've described. and you're tensioning it so that the cascade is a bit tighter than the remaining finger. So you want to put in the graft so that at the end of the procedure, that finger is more flexed in than the others, because it will stretch with time. And you can always check it by doing the tenodesis effect, where it is that it's coming back and forward, because and again, ideally, as you do the tenodesis effect, the grafted finger should still be remaining in front of the non-effective fingers. So I access the silicon rod at the second stage of the two-stage by opening up the scars of the distal incision first of all, finding the distal end of the rod. I then go to the palm and I find the proximal end, and I always mark it with a stitch so I know where to find it, because it's clear. It can be a bit difficult to find, so putting a colored suture around it makes it a bit easier to find. You take the graft of your choice, and here we see I've already passed it through. So what's happened here is I released the rod distally from the FDP stump. I've attached the rod to the graft, and the rod has been pulled out via the palm, and now the graft has gone in from the distal end over the DIP joint to the palm, and it's now lying inside the pseudo sheath. Complications, well, you can get synovitis, particularly if the really keen patient is really mobilizing before their second stage a lot, and they can actually get a silicon sort of synovitis of the finger. They can rupture the distal end where it's attached to the FDP, to the stump, to the distal phalanx. They don't always know this has happened, but some patients seem to know when it's gone. And if that happens and you get an ultrasound, it confirms it, then you're looking to try and immediately go to the second stage. And they can get adhesion still to the silicon rod itself. Once you've done the second stage and put the graft in, they can of course still rupture at any point, as could with a flexor repair, but of course the graft is a little bit thinner, so the chance of rupture is a bit higher. You can still end up with a flexion contracture if you haven't left the campus chiasm or done something to secure maybe one of the slips of FDS at the PIP joint. They might get recovatum deformity, so they've got hyperextension at the PIP joint, and you get bowstringing if the pseudotendon isn't strong enough. Infection is rare. Obviously, you have to treat with antibiotics, and will almost certainly have to remove the implant. And extrusion is possible. Normally, it means it's ruptured first, and they're still doing the exercises, and it eventually just extrudes through the skin. Thank you very much.
Thanks, Tony. Now, again, in the interest of time, I'm just going to move straight on to therapy considerations following on from tendon reconstruction.
We've decided to go down the route of a two-stage tendon reconstruction. Patient comes to you, we've put a silicon rod in place. Sometimes we put the silicon rod to the palm, sometimes we put it to the wrist. What would you do from a therapy point of view?
So at that point, we've got to make sure that you're getting movement out of that joint, but you don't want to overstretch it. So we block them into two exercises. So we do a passive hook, and we do a passive isolated MCP movement to make sure the joints are keeping moving and keeping mobile. What we've got to be careful of though for the first sort of up to 4 weeks even is to be careful that we're not doing full composite stretch on that finger in order not to displace that rod or cause any problems with this first stage reconstruction that's been done. So after that time we have a bit more ability to stretch and keep things going, but in the first instance we don't want anything to seize up from a joints point of view, so we've got to do that hook, we've got to do that isolated MCP, but after that period of time we can work towards composite and make sure they're supple. Scar management is also important still at this point, so in order for them to go ahead from a second stage point of view, scars need to be supple, they need to be mobile, the finger needs to have the swelling under control, and the soft tissues ready to be able to have the best outcome having had a second stage. It's also important to bear in mind again all the other digits and make sure they're using and moving them as much as possible. So they are fine to stretch from day one, and they are fine to do light use of them, and not to exclude the hand in its entirety.
What about after a second stage tendon reconstruction? Say, for example, we've taken palmaris, and we've inserted that, so that's spanning from the wrist all the way to the fingertip, or from the palm to the fingertip. Would you do anything differently with that?
We literally go back to how you would manage a primary repair. So they would go in a long dorsal splint, as we were talking about, and they would start their exercises and their exercise regime as per their flexor tendon protocol as normal.
Would there be any difference if you had done a shorter graft or a longer graft, or is the regime the same?
The regime stays the same. We're talking about where those points are, so even if it's into your palm, that would end up being zone 3, so we still put them in a longer splint.
There's 2 points of repair, so there's where the tendon is inserted into the bone of the distal phalanx, and there's the weave as well. Generally, we would like to think that these are stronger than doing a primary repair. Do you get patients going any quicker, or do you treat it with suspicion and keep the protocol the same?
Yeah, so we keep the protocol the same, but as with any patient that we treat, how quickly we progress and how we change things really just depends on that individual. So with those patients, we would keep them going as normal. We'd expect that to be a fairly strong repair if it's had a weave going through it, but we also know that we need to just be a little bit cautious not to overstretch and overpush on things. These patients tend to be a bit more cautious, especially if they're a re-repair anyway, because they've ruptured it once, they don't want to do that twice. So they tend to be a little bit cautious in themselves, so sometimes we try and push them on a little bit more, but likewise they might be the ones that have gone back to work too early and we have to hold back from what they're doing, so we just judge it according to how the patient is.
Oh,
Okay.
we may have had another video failure.
No, we're done now.
Was it? Okay, sorry. I that was suddenly abrupt, and yeah. Thank you. So that's kind of the last of the formal presentations, as it were. So I'll just turn my video on. I just realised you can't see me. So thank you very much to, we've done really well. We've kept 200 delegates here out of, I think we peaked at just 300. So thank you very much, everyone who's stuck with us. Apologies for the technical glitches, but I think they're fairly standard with Zoom and all that. And the videos, we will do our very best to put as many of them on the YouTube channel, how to be the recording of this whole webinar on the YouTube channel, but the individual videos I think will be really useful. But let's move on to the home straight. Do some Q&As, and then we've got some case discussions. I'll keep the Q&As brief, if that's all right, just because of time. There seems to be a very niche question which perhaps can be answered individually about something called the Peneva-Holovich technique, which I don't know. So I'll leave one of you guys to answer that separately. Now,
I can do it quickly now if you want. I mean, it's very quickly. So FDS and FDP, if you've got 2 stumps of them remaining, then it's a 2-stage where you actually join the FDS and the FDP stump together. Let's say it's in the palm. And then what you do is you go at the 2nd stage, you release one of them. Let's say you're going to just repair the FDS. You're going to release the FDP proximally and then rotate the whole thing forward, because it's already attached to the FDS. That's going to become your graft that you can put down into the finger.
Thank you. And then there's a question here: when you have the FDS intact and you want an FDP reconstruction, how can we avoid adhesions between the two?
With difficulty.
Yeah, it goes back to, are you really sure you want to do this? The answer is that if you decide that you are, that you just get things moving, and you get things moving really early. Isn't that right, Sarah?
Yeah, I think it's just that focus on the differential glide when you're doing your exercises and making sure they're following them well enough.
So yesterday I did a case where I had exactly that, little finger, FDP divided, FDS intact. Because it was a little finger FDS, it wasn't very powerful. but the finger itself was moving fine. I know that if I'd open up that finger and try to reconstruct the FDP, I'd have ended up a not very powerful finger to a completely stiff hook. So other people might do better, but that's I'm sure what would have happened with me. So I actually put the FDP onto the FDS in the palm to power it. So they've now got a powerful little finger FDS. They can do both tendons onto one. And then I'll come back and fuse the distal joint later on.
Yeah, you just have to be careful your range of movement's right, but under WALANT, that'll be perfect.
Yeah.
I mean, I think, you know, that one of almost every talk I give on other subjects, I'm always going on about know when to not operate. That's a real skill. And I suspect in hand surgery, that's particularly, it applies. You know, we can all operate, we all can grab a knife and a fork and stick a light down on top of the patient and get on with it. But actually knowing when to not operate, I think is probably reading between the lines of all of what you've heard today. Anyway, on that note, I'm going to sort of bow out, if that's all right, as your host, and I'm going to hand over to Wee Lam, who's going to talk us through some case discussions, and then we can have a bit of discussion as a group after that. But thank you very much, everybody, and hopefully catch you next time. Wee, over to you.
Don't go just yet, Naveen.
Not going to go. No, I'm here. I'm just. But
yeah. So,
over to you.
Okay, I know it's we're supposed to end at 4:30 UK time, but this session will be recorded. So if you have to go, please feel free to go. But this I hope this case discussion will really consolidate the information that you have learned. We're going to show a couple of cases. The other thing I want to highlight is that I know that in a lot of situations, you don't get isolated injuries. You don't get just an isolated FDP injury or isolated extensor injury. You get tendons injuries with lots of soft tissue defects. So these couple of cases will illustrate that. And we're going to just really whiz through this. And I'm going to ask the panel for their thoughts. We're not going to have a lot of time to discuss every case, but the idea is just to discuss the issues surrounding these cases. So this is the first patient. This is a 55-year-old who 8 years ago, this is a courtesy of Ganga Hospital because they see the kind of cases that you see. So the patient had a volar wrist plating, and then 1 month ago, suddenly he's unable to flex his thumb. So questions, what would you tell the patient? Tough, that's it? Or what are you going to say to the patient? Tony, over to you.
Well, it's very likely to be an attrition rupture over that free edge of the volar plate. So I'm going to explain to them that the plate needs to come out. Because it's an attrition rupture, I'm unlikely to be able to do, I won't be able to do a primary repair. The quality of the two ends won't be suitable. And then I put a lot of things on a consent form. I say it might be possible to do an interposition graft if there's a small area. There, I might be putting in a silicon rod, but if it's fine to go ahead and do a direct one-stage reconstruction there and then that would be my preferred choice.
Okay. That's great. Sarah, any thoughts? What will you tell the patient? Dave, send this patient over to you first.
Yes, well, it come back to making sure that they could move everything. So they've obviously lost the active movement, make sure they've got that passive range and that they understand everything. Just doing a pre-op sort of education of everything and making sure they could do it all.
Okay, Dave, what are your reconstructive options?
So I find that if you're not in the fingers, that usually you can get a graft in or a tendon transfer in straight away. So if this was a problem up in the fingers, then almost certainly you'd be looking at a silicon rod and a two-stage. But for here, I found so far that you can get away with or not get away with. You can put in a graft straight away or do a tendon transfer. So you can either do interposition graft, or you can take typically FDS of ring finger and flip that over, but graft would be my favored.
Okay, right.
We'll add one other form of type of reconstruction. If it's a sort of a 4 centimeter defect, rather than take a graft, you can do a tendon turnover. You actually split half of the proximal tendon and flip it over and then attach it to the distal component, and that works quite nicely.
That's great, Tony.
As long as it's not in a sheath.
Now we're gonna see whether everybody has learned something during this webinar. We're gonna set up our first poll, so everybody can you see the poll? Right, everybody in the audience, please vote. What would you do? So the first one is I will remove the plate only and do nothing. The second one is remove the plate and try to repair the FPL. The third is to leave the plate alone and repair the FPL primarily. The fourth is to remove the plate and reconstruct the FPL with a tendon graft. And the last is to leave it alone. The patient can cope. What's the big deal about not being able to flex your thumb? So let's see what most people do.
Maybe you should have put the poll up before we answered.
Well, you didn't teach that today, so we can't expect that indeed. Okay, well, you can see most of the people have decided to remove the plate and reconstruct the FPL with a tendon graft. So that's very useful. So let's see what was done here. So this was a palmaris longus graft. Is that right, Dave?
Yeah, I think so.
Okay, so that was the best tendon graft. Tony has said, if you don't have a palmaris longus graft, you can use the plantaris. You can use the palmaris on the other side, or you can use a toe extensor. And then this is a pulvital weave into the FPL. I probably might have opened up the carpal tunnel, but everybody is different. And then weave it into the FPL proximally. Anything to say about the tension setting here, Dave, quickly?
Yeah, you do a tenodesis on the wrist, and you make sure. I mean, WALANT makes it very easy, but in the days pre-WALANT, you would make sure that you could get your thumb to touch the pulp of the little finger with wrist flexion, and then as you extend, the thumb should come out beyond the other fingers. But generally, a little bit too tight is better than a bit too loose.
Okay, just to mention that we at the end I will promote this. We are going to have a 2-year webinar series, and one of the session will be on tendon transfer. So this is just to really whet your appetite. Right, now second case. Now this is from Mozambique, Petro Santos. Thank you very much for this case. So this is I'll play the video in a minute. This is a 55-year-old lady, unfortunately, who had a necrotizing fasciitis of the right hand and forearm. Treatment was delayed because of ill health, and because of that, she had skin grafts on her right hand and forearm for the flexor and extensor, and now she's ended up with a very stiff hand. She can just about oppose her thumb to the little finger, but very limited passive movement. She wants to improve the function of her hand. So let's hope the video plays. So this is from Petros. Okay, over to you, Sarah, first of all. So what are your thoughts?
So the general stiffness is the first thing that you've got to work on. She's obviously got significant adhesions sort of going through into her palm that are stopping any of the movement of the long tendon glides. She also got sort of that cupped hand posture that you need to get away from to try and get everything on stretch. So it goes back again to that whole, if the joints aren't moving, if things aren't supple, then you can't really get anywhere from a surgical point of view either. So it's a case of starting from the beginning, blocking those MCPs, getting the IPJs flexing in by passively getting them moving, to then see what can be done from your side of things, really.
Okay, Tony, any thoughts?
Yeah, I mean,
this is a fresh case. We don't have a before and after, so
yeah. I mean, I think one of the things you've got to temper the patient's expectations, it's going to be difficult to get a really excellently functioning hand here, I would suggest. It would be nice to see some passive movements just to see what the joints are like of the fingers, first of all. I mean, is this mainly tethering at the wrist level? Is there additional tethering at more than one point? Because then you're otherwise, this is almost going to be more than 2 stages, but you're looking to free up and release tendons and put good soft tissue over the top of where it's all tethered in the wrist. Would you even consider just releasing the wrist flex and extensors first and try and get movement of the wrist? Because if there's better movement of the wrist first, you can come back and do the finger flexors later on. It looks quite old. I think if the fingers are likely to be stuck down as well, and so then I'd probably aim at trying to move up the proximal joints first of all, later on going down to do grafts, probably flex some silicone rods to the fingers, but very difficult, very difficult. I'm not sure, because there's so many fingers involved, you might just want to leave a tripod grip for the index and the middle and not try and get them flexing all the way in, and then try and give a power grip by just focusing on the little and the ring. But it's a difficult case.
Okay, I wonder if Dr. Nongu or Peter has any views. Naveen, any views? I'm going to launch a poll now, okay? Before I ask David to think about this. So let's everybody please participate in this. What would you do? First of all, would you remove the skin graft on the flexor aspect only and cover with a flap and do secondary tenolysis? Would you perform secondary flexor tenolysis under the skin graft? Would you remove the skin graft on the extensor and the flexor, cover with a large flap? It will have to be a very large flap, and then perform secondary tenolysis. Or would you leave things alone? Because there's already wound healing, the wound is already healed, just accept a limited function. So let's see what most people think. And this is a really difficult one.
And if there's any way we can see the poll result, that'll be great. I don't think we quite caught it last time.
Oh, I see. I don't know how to do that. Emma, can you do that?
Yeah, I can do that.
Okay, you do that. Yeah. Okay, I think that's about it. Emma, do you want to put the poll results up? Okay, interesting. So most people think that you just about beat option C. You will remove the skin graft on the flexor aspect only, cover with a flap. That means most people think that let's concentrate on the flexor aspect because you can't really solve everything. Dave, what do you think?
Yeah, actually, probably none of the above. So I would start first of all with therapy, maximize the range of movement and everything that I've got with therapy. So at least we can take out the interstitial stiffness and tightness, and we can take out the joint contractures as much as possible as part of that. If at the end of that you've got a reasonable range of movement, then if the tendons are intact, which I think they are, they're likely to be stuck in one of 3 places, and that's where your 3 skin grafts are. So there's the dorsum of the forearm, there's the palm of the hand, and there was there another? There was one a bit more proximally on the forearm, wasn't there? Yeah. So got proximal forearm, palm of hand, and dorsum of forearm. On the video, when the video was playing, it looked as though there was actual reasonable movement underneath the forearm and also on the back of the hand. And the way that the hand has come in, it's as Sarah was saying, that sort of cupped posture. It looks to me as though the majority of the problem and the adhesion is in the palm. I kind of reserve judgment on that because it's on the video. So my view would be to go into the palm first of all. That's if I'm fairly happy that it's moving fairly well there and there, and I would do a tenolysis at that point, and almost certainly have to put a flap on at the same time, be that a Becker flap or reverse radial. Yeah, it'd be a Becker flap probably, if not a free flap or a grind flap.
Okay, thanks. There is a comment on the Q&A maybe the best to use CMMS. Maybe Sarah, you know what that is? I'm not familiar with that. Do you know what that is?
So I'm going to go with the fact that it's like a controlled motion machine that they're probably using, like a CPM type machine.
Yeah.
You can. We don't have them. We don't tend to use them. I find getting actually hands-on with a patient is important, and teaching them how to do it when they leave, so that they can actually continue with it. It's all very good doing it in your therapy session, but it's what they do outside of it.
Okay.
So, yeah.
Okay, and then we can leave it for another session to talk about what kind of flap we're going to use. So this is another case. Again, Katusia Ganga, 34-year-old man. Now the extensor aspect now. Assault injury of a blade, and now he's unable to extend his digits for obvious reasons. So question, what will you tell the patient? What are your considerations? What are your reconstructive options? Dave, over to you first.
Okay, so what we have here is it looks like a post-debridement view, and there's a gap in the extensor tendons, and from that image it looks as though the gap's in EDC. It looks as though it's probably in ECRL and ECRB as well. I'm not so sure about the thumb, but that may well be gone. So when you've got a gap like this, actually, if it's relatively fresh, or even if it isn't, you're better off just taking some tendon graft and putting that across. Here, where you've got multiple tendons, actually, I find that fasciolatus is quite useful, and there's a couple of different ways of harvesting that.
Okay. Anybody else want to comment?
I'd say that if the patient can't come back for rehab, I wouldn't repair the extensors. I mean, they're just going to lose function at the MCP joint, but they'll still be able to extend at the PIPs. And if their flexors are intact, they'll just have a hand that just get the wrist extensors repaired and
Okay.
leave the.
Emma, do you want to share the poll so that everybody can have some fun with this? Okay, so let's look at how everybody will respond to this. So option A, try and repair the extensor tendons primarily. Option 2, perform a tendon transfer using a wrist flexor tendon like an FCR. I'm talking about the EDC reconstruction. Number 3, use a tendon graft fascia lata. Number 4, use a tendon graft multiple toe extensors. That's another option. Number 5, do nothing except limited function. Another option, obviously, is a wrist fusion if the wrist extensors are gone as well. So I'll let you share the poll results, Emma. So there's a useful link shared by Hans van der Berg. I think that's about the CMMS for everyone, if you want to note that down.
Can everybody see the Q&A, Emma?
Can you not see it?
It might be. If not, I'll just copy it through.
No, you mean the poll?
No, the Q&A we can't. With the poll results we can see now. There we go. I'm just wondering about the Q&A. I'll copy the link that Hans.
Oh right, I see. Yeah.
I'll copy that across and I'll put it in the chat.
Okay, so majority will use a fascia lata graft. If you're not familiar, I'm just haven't got a picture of that. Yeah, so fascia lata graft, lateral aspect of the thigh, that's the fascia lata, and then you can cut it into different strips, and then you roll up the ends, and then you use that to reconstruct the different extensors. So again, this is the kind of thing we can expand on a little bit more in future webinars. I'm conscious of time. I'm going to move on quickly to the last case. So this is one of my patients, 30-year-old, crush injury to the middle finger, now unable to extend the PIP joint of the finger. What will you tell the patients? This is quite a common injury, actually, but quite difficult sometimes to solve. Now, over to you, Dave. What do you think?
So if you analyze what's missing, it's a relatively small defect, but it's affecting the PIP joint distally. You've certainly got P2 exposed, and that's raw. You're missing central slip, you're missing the radial lateral band, and then there's a hole in the skin over the top. So I tend to get a little bit anxious when you've got all three elements of bone, tendon, and skin missing, that if you try and do something with the tendon, it's going to stick. You might be able to get away with it here because it's the surrounding area isn't a huge zone. There isn't a huge zone of trauma. This looks like a sort of a router type or scoop type injury. I've done a couple for small areas like this there's a little flap that you can do, which is a reverse digital. It's described as the reverse digital artery flap, but actually you don't need to take the digital.
So Dave, would you do this as a 1 stage or 2 stage with the tendon reconstruction?
2, I think.
So you cover the skin first and then do a tendon reconstruction in another stage.
Yes.
What about you, Tony?
I think I do it as a 1 stage, actually, as long as the collaterals are intact, and I'm happy to move the PIP joints straight away. And if I can get a flap which will allow movement in place, I think, a little bit of jogger movement to keep the PIP moving. A Miriama or a Kawaba flap would probably be what I do.
Sarah, do you want your surgeons to do it in a 1 stage or 2 stage?
Depends. It depends. I don't think there's a good answer. If you get coverage and things will move, then we'll go for that. But if you're going to cover it and reconstruct it and we can't do anything with it, then I'd rather not. So.
Okay. Any other comments?
The therapist is the boss. I was also going to say, with the last case, the fascia lata I would go for every time, because I've had my fascia lata harvested for an ACL reconstruction. Worked brilliant.
Okay, so I mean, obviously, we went back and forth. I'll just quickly tell you what we did. So we opened up the finger, and this is what we found. Even the other lateral band is kind of really not in good shape. The central slip is gone. The lateral band on here is gone. So it's kind of a big defect. You could think about a turnover flap, but I'll tell you what we did. We did a sort of a hatchet flap, and David Evans described this actually. It does actually move quite a lot, and this will allow you a 1 stage reconstruction. And what we did was we take 1 slip of the FDS. This is described by Pickford and Ahmed, where you thread it through from the volar to the dorsal, and you do a 1 stage reconstruction with a 1 slip of the FDS, and then you cover it. And then, so this is a 1 stage reconstruction. Let that heal, K-wire, heal for 4 weeks, and then get moving. But there are lots of different reconstructive options. I think this is the one that, this is one of the ones. This is an adipofascial turnover flap. You could do a reverse cross-finger flap. Then you have to do a 2 stage cross-finger flap, reverse cross-finger flap. But we're going to cover all these things when we come to the session on soft tissue cover. So this is just to show that if you have something much more proximal, you can do a 1 stage. I always will try to do a 1 stage reconstruction. It's just better for the patient if it works. I don't think we have time to discuss this case. I'm not going to ask you guys to talk about, but obviously here you have to think about whether you want to reconstruct the extensor tendon. Now I'm gonna hand over to Naveen at the end, right at the very end, but I just want to bring everything to a close and then hand over to him. These were the learning objectives at the beginning, and I want everybody to look at these learning objectives. And I really hope that you will feel that you have managed to achieve most of these learning objectives. You have an understanding now of the essential anatomy of the flexor and extensor tendons. You have you understand the principles of flexor tendon repair, extensor tendon repair, very importantly, the essential components of a successful therapy regime, and a strategy for salvage procedures. Obviously, a webinar like this is limited in what we can teach, but these were the learning objectives we set out to achieve, and I hope you have managed to achieve most of this. I did want to have some multiple choice questions, but the technology has not worked. I just want to spend a minute or so letting you know about the next series of hand surgery webinars for 2021 and 2022 run by BSSH and BFIRST. This will start in April and they will run over 2 years. And this will be monthly webinars. And my screen has froze. Can you guys still hear me?
We can still hear you.
I'm trying to
see the
get
BSSH and BFIRST logo. That's what you're sharing.
Yeah, I'm trying to get out. Hold on a minute.
Where we just had a question about where will the link be for the next webinar. So if Emma, I don't know if you're able to put that in the chat before we close the Zoom meeting, that would be great.
Yeah, I can do that now. I've not actually set the webinars up just yet, to be quite honest. They will be on the BSSH website, and they'll be emailed to everyone on the BFIRST and BSSH overseas mailing lists, which is where most of the delegates from today came from. So I would just suggest keep an eye on your emails, keep an eye on our website, and you'll find the links very soon.
Well, just as you managed to get onto today's webinar, because through Twitter or social media or word of mouth, hopefully you will be able to get access to this. But they will be both on the BSSH and BFIRST websites. Just to give an idea about the topic, so in April, we start off with the mangled hand. We touched on WALANT today, so we're going to expand on WALANT a lot more in May with Don Lalonde. And then in June, I'll talk a bit more about that. We're going to come back to tendons again, and then raise soft tissue injuries, nerves, and all sorts of different topics that we'll cover and throughout the next 2 years. So
is there a Facebook link, by the way? That's one of the questions. Do we have any? I don't think we've got a presence on Facebook, or do we? Am I wrong about that?
We do. Both BSSH and BFIRST are on Facebook. Just search for the names and they should appear.
So we can put all this on Facebook.
And all these webinars are shared there as well.
Right, thank you.
So just a word about the tendon webinar. I know today was a tendon webinar, but in June, we're going to have an even longer tendon webinar to expand on some of this. Now, this is stretched over 2 days. The first day is 5th of June. This is our normal BSSH instructional course in hand surgery on tendon injury, rehabilitation, and hand transplantation. This will be for the whole of Friday, 4th of June. At least for 6 hours. This usually you have to pay a fee for this, but we will be giving complimentary registration to hundreds of participants. So we will send out the link for that. Now, on the Saturday, we are going to have our own breakout session. So Tony will run that. So we're going to have a 2-hour tutorial on Saturday to consolidate the knowledge on the Friday. So that's what's going to happen. Now, Naveen, I'm going to pass this over to you to talk about feedback, certificates, and recordings.
So thank you. Thank you, everybody who has spoken. Thank you to all panelists. We haven't mentioned Malika and Katie, who are two people that have been working in the background, fielding questions and helping us keep things moving as well. Thank you to Emma from BSSH, and who's been the sort of brought the webinar together. And thank you to our co-panelists from Tanzania, Dr. Nungu and Dr. Mwandiga. And hopefully this is, as we has just said, a real taster. I mean, it's certainly been the most education in hand surgery I've had for a long time, but that's not saying very much for because I don't, as I said, I'm not a hand surgeon, but it's been really interesting actually. I think one of those flaps you presented was that the Merle flap, from Pickford. Thank you everyone for attending. I think we've had, the number of people still showing as participants is amazing given how long we've been going and how much we have overrun as well. So apologies for the overrunning, but we will get this right more and more as we do this with the webinar series over the next couple of years. In terms of certificates for attending, I'm guessing those will come back to you after you've provided us with feedback, or certainly that's the way I would like to see it happen. Please do give us your feedback, be brutally honest and tell us what we can do better, and join us for the next series in due course. I hope it's been fun. I don't know if there's any last words from any of the panelists, rather than me just wrapping things up. AOB from the panelists. Anyone want to say anything?
Yes.
Yes, please, Dr. Nungu, yes.
Yes, I'd like to talk from Tanzania on the COSEXA side. We are very grateful because around this part of the world, in 12 countries, probably there are not more than 12 or 10 hand surgeons, so to speak, and there goes with handy therapists. So this you are planting a seed, and from this, with this series of webinars, people will catch up, young people will catch up, and probably will have experts coming up. Thank you for this. Thank you, BSSH and the BFIRST. Thank you very much.